Good morning and welcome back for our Ancona Live course, Minimal Invasive and Transcatheter Cardiac Surgery, day 2. I think yesterday was a very good day. I'm really so happy. We have an incredible attendance. We have, I don't know if they can put some numbers on the screen. We had 2,090 attendees, but that's not so much. The most important thing is that we have people coming from 30 countries in the world. The list of the countries is just incredible, from Mexico, Italy, of course, Europe, Mexico, India, Sri Lanka, Ukraine, United States, Norway, Republic of Korea. Incredible. This was really international, and this is going really far beyond my best expectations for us. This is Ancona. We're not in Milan, we're not in Berlin, we're not in London, and this was the first course we're giving in person, so really I'd like to express my heartfelt gratitude for the efforts, the huge efforts you've made to come here believing this was worth it to do. So thank you very much for being here. Thank you. And also I think the program yesterday was pretty good. We made a focus on primary MR interventions, minimal invasive interventions for primary MR. You had presentations in the morning. I'm really glad we were able to show you 2 minimal invasive cases, transaxillary done by me and endoscopic from Marco Solinas from the beginning to the end, not just how to fix a valve, but first of all, how to get there to fix the valve. I think that was really important. I hope you appreciated that as well. Probably, Alessandro, we can connect to the OR because I'd like to give you some information about our yesterday patients. And probably, Michele, we can't hear you. Just wait a second, please.
Okay.
Okay.
Can you hear me now?
Yes, we can. Please.
Okay, good morning. So just some brief updates from yesterday's patient. This was our patient from ward number 2. And this is him now. So the patient was extubated on table right after surgery.
Michele, wait.
Yes.
They have to understand which patient you're talking about. So this is
Yeah, sure. This was the patient in OR number 2, the one treated with the transaxillary approach. So this direct view, mitral valve repair and tricuspid valve repair.
Yes.
This is him this morning. He was extubated on table right after surgery. He is now awake with no neurological issues, no inotropic support and sinus rhythm. You can see his chest x-ray, and this morning blood gas is on the slide. Diuresis is fine. Total bleeding was 150 milliliters. So the drains will be removed in the morning and the patient sent to the regular ward. Okay, well, this was our patient from OR number 1 with the fully endoscopic treatment. So this patient was also extubated on table after surgery. The chest x-ray looked fine, but he returned to the OR during the night for bleeding after 1 liter of total leakage from the drains. Small bleeders were found on the trocar sides and on the chest wall. So now total leakage after chest exploration is 50 milliliters. Blood gases are okay. The urine output is stimulated with Lasix. The plan is to proceed with the extubation in the morning. That's all for now, I think. Thank you.
Yeah. Thank you very much, Michele. Thank you so much. So before we start with the sessions this morning, there is an important moment that means a lot to me. So I would like to introduce and invite to join me on this stage a person that means a lot to me. Is a true leader. Is a person that really knows how to carry out projects. Is a person that is an innovator in his mindset. I can stay here for 1 hour now. Is a person that is always supporting me, my team, cardiac surgery, and every time I go to him to propose a project is accepting that and adding value with new ideas to put on it. And this person is our Magnifico Rettore, Professor Gianluca Gregori. Please, I'd like to have you on this stage, please.
Thank you. you, Marco. Thank you for your presentation. Good morning, everyone. We are honored by your presence here, really. It's unusual for me to open an international meeting. We have seen many researchers from 30 countries at 8:30. You have to be strong workers, so really, you have to work
Certainly,
very much.
the early riser.
My name is Gianluca Gregori. I am the director of Ancona Università Politecnica delle Marche. Marche is the name of our region. We have various branches in all the regions, from the southern to the northern. About 17,000 of students, and 5 different cultural areas: medicine, naturally, but also engineering, economics, science, agriculture. My staff has written a speech. I read only a little bit. Our university is a dynamic institution. Its young and energetic teaching body has got a very interdisciplinary attitude and broad outlook to the world. All departments have multimedia classrooms and modern labs, as well as specialized labs devoted to advanced research. But it's true, really. I'd like to offer the seal of our university as an acknowledgement, and I am here today to reward 2 extraordinary surgeons. Professor Urs Kappert. Where is Professor Urs Kappert?
Please.
Professor of Cardiac Surgery at the Dresden University in Germany, for his continuous, precious, and altruistic collaboration with our university hospital and our research center that Marco directed.
Yes, yes, I like. Yes,
please.
I can explain the motivation of the
Sure.
of the rector. You know, I can talk about our friendship and our professional network relationship for hours, but I'd like to focus on 2 subjects basically. One, very important for me and my team and for our cardiac surgery. About 6 or 7 years ago, we started a TAVI program in cardiac surgery, and you know, when you have friends, we were always in touch, and I told him, I really want to do this. And he said to me, you come to Dresden, we will teach you. And that's what I did. I went there for 2 weeks together with my 2 senior surgeons from my staff, and I can't forget the way he entered the hybrid room the first morning. We did 50 TAVR in 10 days, 5 TAVR per day, and he said, entering his hybrid room, so this is Professor Marco Diosano. He is my friend. He wants to start a TAVI program in front of the cardiologists, surgeons, nurses, all the stuff there. He wants to start a TAVI program, so we have to teach him everything. When he goes back to Ancona, he has to do it. And that's what happened, basically. So if now maybe next year we reach 1,000 TAVR done by cardiac surgeons alone, this is thanks to him. And this is a picture. You see, this is my first TAVI in a Dresden patient. It's clear I am a beginner there. I'm looking at the groin while he's looking at the screen, the way it should be done. So thank you, Utz, for this. And second subject, the transaxillary. We were visiting each other. I'm going to Dresden, he's coming to Ancona, and we plan to do some cases together. And we had a redo mitral valve repair after CABG, 6 distals, not surprising me at all 6 distals were done by my father, they were all patent after 15 years. And he said, you know, I'm just back from Miami, I saw these surgeons, Joe Lameras, maybe if we enter the chest more laterally, we can have a good exposure. And basically, this was my first transaxillary MVR. The video should be going, because it's nice to see, sorry. Anyway, this was my first transaxillary case. It was a beating heart, a redo mitral valve repair, and we did it together. So I think now, Utz, you can be very proud by the fact that, you know, the way we've been learning from you, now we're trying to teach others, and then we have surgeons that are coming to learn how to do TAVR, how to do transaxillary, and this is thanks to you. So I think it's very nice to say thank you to someone when you really mean it, and I really mean it. Thank you, Utz. Thank you very much.
Thank you for your collaboration and our cooperation with our hospital and with Marco. Thank you very much.
Come on. Thank you. Thanks a lot. Thanks a lot. I have a gooseneck anyway, yeah?
I know.
But I'm a little bit excited because your team, your beautiful team in your beautiful hospital, I think is still waiting.
Yes, you have to go to work. You're not here for holidays.
For the picture.
Yes. But maybe you can wait 3 seconds for the picture.
Yes,
Just wait 1 second. And then maybe it's not finished yet. No. Maybe you allow me to say...
No, but it's a surprise.
Yes.
We have to say that we have a second seal, really a great surprise. Thank you very much.
Yes, and this is going to be really personal. Nobody is perfect, and nor I am. But, sorry, I'm a bit... So I could certainly be a better surgeon, a better chief, a better teacher, but also a better man, a better father, a better husband. For sure, I would be much worse than what I am without the great inspiration from my father. Giuseppe Diosagno, please.
Please, Professor Diosagno. The seal.
It's not a good thing.
The seal of our university to Professor Giuseppe Diosagno, former director of the Cardiac Surgery departments in Teramo, Ancona, and Bari, for his long and extraordinary career as a cardiac surgeon dedicated to patient care and innovation. Thank you very much for your presence here, really.
I think you don't have to say. Come here. If someone asks me, if someone asks me, give me your ranking for the most innovating surgeon, this is an easy question to answer. And this is my father. He was doing 25 years ago 2 robotic mitrals per week, and the other 3 days he was doing robotic cabbage. I'm sorry to disappoint you that I'm direct view surgeon at the moment, but this is the way. This is a surprise. He didn't know anything about it.
I thought to stay in my boat in Greece now, and I am here, and I'm really I'm very happy. Thank you very much. I enjoyed this meeting very much, and I thought to see the things we were able to do some years ago.
Yes.
Thank you very much, Marco. And thank you very much
for the picture.
Thank you.
Utz, maybe you can come here for a picture.
Marco, may I
Yes.
try
Sure.
to... If you... Oh, Professor, here. Your hand here? I give this?
Yeah.
Also this?
Yeah.
Thank you. Please, a picture.
Yes.
Not good.
Thank you very much.
Thank you.
So I have to go. We have many events in this morning, another international meeting, but it's been a great pleasure, honored by your presence here. Have you good work and many compliments to Marco.
Thank you very much. Grazie mille.
You keep me so off track, yeah. Been spinning up for miles, but I think that you like that. Can't deny it. You're bringing my life back, yeah. You're doing it in style. You came with that jetpack. Now we're flying. Every time I'm with you, like a time machine, making everybody jealous like you're 17. I'm glad you're the cover of a magazine. Got me feeling like damn, hey. Oh my God, don't know how you do it like that. Yeah, oh my God, don't know how you do it like that. Blow my mind, just somehow you bring it right back. Yeah, oh my God, don't know how you do it like that. Yeah. Some things you can't fake, yeah. Some things you just feel. Got plans we ain't made yet. Yeah, it's forever. You throwing that drink back, yeah. You staying a while. You rocking that fit that's making all them strangers smile. Every time I'm with you like a time machine, making everybody jealous like a 17. On God, you're the cover of a magazine. Got me feeling like damn. Oh my God, don't know how you do it like that. Yeah, oh my God, don't know how you do it like that. Oh my God, somehow you bring it right back. Yeah, oh my God,
Welcome to this morning's session. That was a great little honor we just saw. So this morning we will have live case number 1, transaxillary mitral valve replacement, tricuspid valve replacement, and left atrial appendage. And room number 2, a mitral transcatheter edge-to-edge technique, otherwise used to be called mitral clip. So now called TEER. Our presentations this morning will be preparing the surgeon for the heart valve team, and we welcome you to our morning session.
Immediately with the presentation from Carla Lofiego. She will be followed by Francesco Maizano. They have to go to the ER later on. So Carla, she's an echographer, and she will talk about echo assessment for mitral tear. Anatomy does matter. Carla.
Yes. Good morning. I would like to thank Marco for the kind invitation. My role today is the echo assessment for mitral transcatheter edge-to-edge repair, the importance of anatomic assessment. We know that the main etiologies where we can use transcatheter mitral edge-to-edge repair are basically 3: degenerative mitral regurgitation for high-risk inoperable patient, and functional mitral regurgitation divided in ventricular function MR due to remodeling and dysfunction of left ventricle, and atrial function MR due to pathology of left atrium leading to mitral annulus dilatation and dysfunction. We know that echocardiography has 2 main roles in this context. The first role is a physiopathologic assessment of the patient. That means to define etiologies, quantification of MR, and hemodynamic and morphofunctional pattern of disease. And the second role that comes after is trying to define the anatomic assessment, looking for criteria of feasibility for surgical and transcatheter repair. Mitral valve anatomy has to be defined looking through different elements, including leaflet characteristics, mitral valve area, reconstruction mitral geometry, and also the evaluation of the fossa valley and the distance between fossa valley and the coaptation plane. That leads to understand if the anatomy of the patient is ideal, if it's challenging but still feasible, or is too complex for the procedure. Leaflet characteristics have to be analyzed in all their features. Morphology, length is a critical point, mobility, calcification at the grasping point or in different area, and also at the level of annulus. For the degenerative mitral regurgitation, we have to define flail gap and flail width. For functional mitral regurgitation, we have to define coaptation depth, expression of tethering of the valve, and coaptation length, that is an expression of reserve of coaptation of leaflet. Even in contemporary series, where there is more knowledge and more experience in this field, the quality of leaflet in terms of fibrosis and calcification, morphology, Carpentier 3A, and the length of posterior leaflet remain critical point for the success of the procedure. I will refer to mitral clip, which is the most often procedure used in the world, and the one that we use in our hospital. The leaflet length of the posterior leaflet is a critical point for technical aspect. We have 2 kinds of clip. The small one, NT, has a 9 mm arm length. The big one, XT, has a 12 mm arm length. We can insert 6 mm of tissue inside the small clip. So the posterior leaflet length has to be minimum 7 mm more or less. But the choice between the small clip and the big clip is not just a matter of leaflet length. It depends also on tissue quality, frailty, calcification, trying to understand the elastic properties of the valve. So if pathology of A2P2, longer leaflet, redundant leaflet favor the choice of big clip, if we have a restricted leaflet, if we have some kind of calcification that increase the tension of the valve, if the mitral valve area is not so big, and if we are working near the commissure, maybe it's preferable to choose the small clip. The anatomy is ideal when we have a central pathology, A2, P2, no calcification, mitral valve area is more than 4 centimeters square, the posterior leaflet measure more than 10 millimeter, and we don't have significant tethering, and the flail width in the generative MR is less than 15 millimeter. This is an example of a functional mitral regurgitation due to previous extensive myocardial infarction. We can see that the leaflet have a normal morphology, normal mobility without significant tethering, and the posterior leaflet measure more than 10 millimeter. The mitral valve area is more than 4. This is an anatomy that seems to be ideal. In fact, the procedure was quite successful with trivial mild mitral regurgitation at the end. The challenging anatomy is when we are working near the commissure, if we have some grade of calcification but not in the grasping zone, if the mitral valve area is between 3 and 4, the posterior leaflet measure between 7 and 10, and there is more significant tethering with coarctation depth more than 10. This is an example of a challenging anatomy in a patient with previous extensive myocardial infarction, very severe left ventricular dysfunction. We can see that there is a significant tethering of the valve. Mitral regurgitation is quite severe, coming from all the central portion of the valve. There is a very restrictive mobility of posterior leaflet. There is no coaptation between a leaflet. The posterior leaflet length measure between 7 and 10, and the mitral valve area is 3.8. This is anatomy that might be challenging for the procedure. The complex anatomy is when we have calcium at the grasping zone, if the quality of leaflet is not so good, like morphology Carpentier 3A rheumatic disease, if the posterior leaflet is small, measure less than 7 millimeter, if we have some cleft that are responsible for mitral regurgitation, and also when the mitral valve area is less than 3 centimeter square. The mitral valve area is a critical point that has to be related to the intercommissural extension of the pathology. For instance, if we have a very extended prolapse with a flail width more than 15 millimeter, and we start with an area that is between 3 and 4, this anatomy might be challenging. To treat the pathology, maybe we have to insert 2 clips, and we create some grade of stenosis, and if the initial area is not so big, that might be challenge the result of the procedure. We don't want to go over a mean gradient of 5 millimeter of mercury at the end of the procedure. The third point that is very important is try to understand the reconstruction of mitral geometry, try to understand the relation between components of mitral valve, try to understand how important is the atrial component in the mechanism of mitral regurgitation. We might have pure atrial functional mitral regurgitation, we might have pure ventricular functional mitral regurgitation, but also we might have mixed phenotype in the context of functional ventricular mitral regurgitation due to left atrial dilatation and mitral annulus dilatation. We know that the annulus dilatation is something that is not directly treated by positioning the clip, and the dilatation of the annulus is something that might challenge the result of the procedure. In this paper was shown that an anteroposterior diameter more than 40.5 millimeter, intercommissural diameter more the same measurement, were related to suboptimal mitral regurgitation reduction after the procedure, especially if these parameters were present at the same time. But it's not just important the mitral annular dilatation. What is important is the relation between leaflet and annulus, expression of coaptation reserve. We have some parameters that we can measure, the coaptation length, but also the ratio between leaflet area and mitral annulus area, and the leaflet to annulus index. In this paper was shown that the ratio between the leaflet area and mitral annulus area was related to residual mitral regurgitation after the procedure. If this ratio is low, that means that we have a scarce reserve of coaptation between a leaflet. This is correlated with residual mitral regurgitation 2 or more than 2 after the procedure. And the same concept is expressed by leaflet to annulus index, the amount of leaflet length compared to anteroposterior diameter annulus. If this ratio is low, that again means low reserve of coaptation between the leaflet, the risk of having mitral regurgitation 2 or more than 2 after the procedure is higher. And this is a paper from Mayo Clinic that showed that it is important the coaptation reserve. When the coaptation reserve is more than 3 millimeter, this is related to more successful procedure. These are 2 examples. On the left side, we have a patient with a natural functional mitral regurgitation, but there is a coaptation reserve, so this is a good point. On the right side, you can see a very, very giant left atrium. There is no coaptation between leaflet. In that case, the atriogenic leaflet tethering by this giant left atrium might challenge the result of the procedure. So, in conclusion, the echocardiography has a very fundamental role in the pre-procedural stage, trying to understand the anatomical complexity, try to understand leaflet characteristics, mitral valve area, of course, jet in location number, and try to plan the procedure before the procedure itself. Thank you.
Thank you, Carla. Questions from the floor? Yes. So, Francesco, you want to come up, and I will never stop saying how much is important. We have a lot of young surgeons here, residents, how much imaging is important today for cardiac surgeons, should be part of the training programs, of all training programs. There is no cardiac surgery without good imaging, and we should know everything about it. Francesco, it's my great pleasure to introduce Francesco Maisano, a true expert in the field, and he will give us 2 presentations in a row. And the first is about how to do it transeptal puncture. Francesco.
Yeah, so first of all, congratulations for this amazing 2 days, really international platea, amazing. Learning a lot from everybody. I try to share what I know about this procedure that has been introduced by Alfieri many years ago. That I can see my slides. Okay, now you see them. As you see, my institution is San Raffaele Hospital, and Alfieri has been the inventor of this technique, which has been for many years, even today, is very criticized, but it has been opening perspectives, including the so-called TEER. Now, before talking about TEER, let's talk about the first step of a TEER, which is a transeptal puncture. And what is a transeptal puncture? Basically, it's the access to the left side of the heart for any endovascular procedure. And if you have a good start, you are going to expect a good result. If you have a bad start, don't expect any good coming. What makes a transeptal puncture good? Must be safe. Has to be done simply, with a simplified approach. It is very simple, to be honest, but more importantly, has to be efficient. It's the first step for success. Efficient means that you should reach the target with coaxiality, with a smooth trajectory to allow the delivery of your devices. And after you have this, then everything else will be very simple. Hopefully, later on in the procedure, I will try to show you what that means. Obviously, we are in a surgical arena. Everybody knows the anatomy of the fossa, and everybody understands that the safe transeptal is when you puncture the fossa valis, which is the only area where you are 100% sure that you go from the right to the left atrium without damaging any surrounding structure. Now, what I think everybody knows is the picture on the left, so the anatomy of the fossa ovalis. What you should know is also the image on the right. And this is the first thing you need to understand. The fossa ovalis is very simple to be recognized by anyone. As you can see here, the area which is membranous, and is in this moment there is a transseptal needle which is pointing on this structure. So identifying the fossa is not a problem. Obviously, around the fossa there are a lot of structures that can be damaged. So we are talking about a procedure which can be very dangerous if you don't maneuver safely your devices. And to maneuver safely means you need to have echo guidance, which is going to guide you during the procedure. And one of the most important challenges in this procedure is that you use a nomenclature to communicate between the two operators. There is one operator who is operating on the device and one operator who is delivering the images. The two operators should communicate in a very consistent way, and today it is absolutely standard practice to use this kind of nomenclature. There is a fossa ovalis which is divided into 4 segments according to superiority, inferiority, anteriority, posteriority, and then you get a low or high puncture, and I will probably show you later on what that means. What is important again is that we have this nomenclature and we have these targets, and we have 3 images, 3 views that are used during the transseptal puncture, echo-guided, which are very simple to interpret. There is a bicaval view to understand whether we are superior or inferior, towards the superior vena cava or towards the inferior vena cava. We have a short axis view that shows us the anteriority or posteriority of the puncture, and then a 4-chamber view that tells us how far we are from the mitral valve. Now comes the most interesting part for a surgical arena. Actually, transseptal puncture has been developed by surgeons. Dr. Morrow, Dr. Ross, they were working on transseptal puncture for diagnostic purposes. And the Brackenbrock needle has been developed in the 50s and still is the same design many, many years after. The material is pretty simple. There is a transseptal catheter, which is called Mullins, or today we use braided sheets. And there is a needle, which is called Brackenbrock, which will be used to puncture the septum. The way you hold the needle is the most important trick that you have to learn. It's not that difficult, it requires some manuality, but basically then after you know how to handle this long needle, you are able to direct the tip of your needle puncture towards the target that you want to achieve. In some occasions, you can even electrify the needle and then use a kind of RF energy-guided transseptal puncture. This is very often a solution in case of post-cardiotomy patients. So in patients who undergo, for instance, a transcatheter edge-to-edge repair or a valving ring after a failed mitral valve repair, or in case you have a floppy septum like this one, which is very commonly seen in patients with degenerative disease. And so to avoid too many manipulations and having the needle going to the roof of the left atrium, we often use electrocautery to cut precisely in the location that we need. The transseptal puncture is done in very simple steps. You puncture the vein echo-guided, you advance the catheter in the superior vena cava, then you pull back the catheter and you puncture. That's it. It is, when you have good imaging and normal septum, it is probably 1 to 2 minutes procedure. And I can show you now quickly a video that shows how it is done. So the venous puncture is echo-guided. We never puncture an artery or a vein without echo guidance today. The system is advancing the superior vena cava under echo guidance. On the left side of the echo, you see the bicaval view with the superior vena cava on the right. You are familiar with this because you do, obviously, the venous cannulation for minimal invasive. Once you get the tenting, you can observe the position, you can measure the height, and after that, you puncture. basically very simple 3-step procedure. Why do we talk so much about transseptal? Because again, it's the first step for a successful transcatheter edge-to-edge repair, where you need to be safe, because the delivery system for TEER is 24 French, which means 8 millimeter diameter device, very large device. You need to be coaxial, and you have to be enough high distant from the aorta and distant from the mitral valve in order to be able to pull back the clip, the clasp of whatever device you are using to grasp leaflets in order to secure them efficiently. Now, important to understand is also the relationship of the intra-atrial septum to the mitral valve. As you see, the intra-atrial septum is basically tangential, is attached to the posterior medial commissure. So anytime we pull back from superior to inferior, we are going from anterior to posterior, and basically a transseptal puncture in the most inferior part will give us the best coaxiality, as you can see here. Here, for those who are not really expert in this procedure, in transseptal puncture, I tell you, the number one that you see here, the red dot, is the location of the transseptal, which you will find in the original Everest trial, which was telling us to puncture superior and posterior. But you see that more recently, we developed a different approach, puncturing more inferiorly, and that helps a lot in terms of the overall functionality of the device, because you have a more coaxial approach to the mitral valve for any mitral valve intervention, including TEER. For those who want to know more about transseptal, we developed a course, which is a 2-day course based on simulation, is a certification course, which I believe is a very important step one for any surgeon who wants to start this practice, which I believe should be part of the armamentarium of any good cardiovascular surgeon who is dealing with mitral valve repair, like Ancona is doing. Now let me clarify, I am a surgeon, and there is no discussion. The largest majority of our patients are surgical candidates, and we do endoscopic in all patients. Some of us are doing also transaxillary. We are half and half in Milano. But importantly, as surgeon, I see patients where I find a good idea to propose a less invasive procedure. 8-year-old, operable. You know, this is not an uncommon case, where we can operate these patients, absolutely, but we can also offer this alternative, obviously having in mind that since they are operable, the result has to be surgical-like. So I don't believe that TEER is a palliation. TEER is a solution that has to be applied to the right patients. So in this patient, at the end of the procedure, you need to have 0 MR, if possible, or maximum trivial. You have to have no stenosis, no residual motion abnormalities. Exactly the same outcome that you want to achieve with surgery. So I call this is a surgical-like approach, where we have one advantage over surgery, which is basically we can work on a beating heart, assessing hemodynamics constantly, which is very useful, obviously, in functional MR rather than in primary. Now, when you go to meetings, and you have somebody telling you that TEER is great, we'll show you how TEER has been improving over the years. So on the left side, you see a slide that is presented almost in every meeting, which is the improvement of outcomes, of hemodynamic outcomes with mitral clip over the years. On the left side, you see the first bar reflects the outcomes of Everest 2, where 50% of patients at 30 days had still moderate or more than moderate MR after a TEER. While today, in current practice, Expand G4 has been a registry that showed that 90% of patients at 30 days have 0 or 1+ MR as a result of TEER. Now, this is not the reality. This is the reality only in high-volume centers. And this is nothing new for a team, for an audience like this one, where we know that mitral valve repair it's a job. It is a dedication. And the same applies for TEER. Because if you look at the STS, at the TVT registry, where you have all comers, also hospitals who are doing less than 50 cases in their practice, or they do very few cases, obviously the rate of perfection means 0, 1 plus at 30 days, is only 65%. So still, good result, good outcomes overall, but if you want to reach perfection, then you have a surgical mind, where you don't accept palliation. Now, how to get the best, then, from transcatheter edge-to-edge repair? We have heard the importance of imaging, obviously, and patient selection is absolutely important. And then I already spoke about the good transeptal, which I think more than safe has to be efficient, has to be the first step to have a simple procedure. You have to understand the mitral valve anatomy. So till now, I think everybody here is ready. We are all ready. Now, fifth point, respect the rules of a good edge-to-edge repair. This is something a little bit more difficult in a surgical audience, because I know that in this room there are still a lot of surgeons who don't believe that this is a good repair. And that's why I think I want to start with this. It's a very old publication that showed how to do this procedure, how to do surgically, how to obtain a good edge-to-edge repair in myxomatous disease. I think yesterday Michele De Bonis showed you already more or less how to do it surgically, but I show you once more, not because I want to show the Alfieri procedure, I want to show how the Alfieri reflects at the end an edge-to-edge transcatheter. And so this is one very common case, patient who has a pectus, we still want to do endoscopic, pectus is going to be not so easy to visualize, and she has already SAM to begin with. So this is a patient where I think the edge-to-edge repair is not a bad idea. So I will go very fast into video. And how do we do edge-to-edge? As you know, very important, you observe the subvalvular apparatus, you find the area where the cords are converging, because we want to see exactly the midpoint of the leaflets, which is not the geometrical midpoint, but is an anatomical midpoint. By the way, this area is the so-called chordal free zone, which is the ideal target for beginners doing transcatheter edge-to-edge repair. And therefore, fundamental, this phase where we identify anatomically the center of the valve, and we try to be as symmetric as possible, and we adapt the length of the suture, the depth of the suture, to the anatomy that we are going to treat. So I don't want to show the full video because you have seen already yesterday. But this is the essence now, and the reason why I believe that if you in this room start doing mitral clip or Pascal, whatever TEER you want to use, you are going to be probably the best operators because you understand the mitral valve. And you need to adapt this technique, which is a special technique. First of all, the first rule is that the suture, this is a slide from probably 20 years ago when I was telling the first time what to do with Alfieri in edge-to-edge repair to interventional cardiologists. But these are rules that can be used also for edge-to-edge. You change suture with clip and say the clip must incorporate the disease segment completely. The clip has to be implanted symmetrically. The clip, the number of clips should be the minimum required to obtain a good result, to avoid stenosis. And the clip size should be adapted to the anatomy. These are exactly the same rules that we use in transcatheter edge-to-edge.
The two presentations in one.
Now, regarding the procedure itself, I told you fundamental is to obtain coaxiality and trajectory, which means, just like in surgery, if you want to have a good result, you need to be precise, you need to be exactly at the millimeter where you want to put a stitch. The same applies for the transcatheter edge-to-edge. If you have a system which is coaxial, then you are under control. The A2P2 area is the chordal-free zone, is the easiest area where you can navigate and avoid complications, getting entangled into chordae. So this is going to be usually the first patient population that you are going to treat, central lesions. And obviously, I don't have to teach you the subalveolar apparatus. As I told you, as I showed you in surgery for edge-to-edge, the same applies for transcatheter edge-to-edge. You need to look at the valve, having in mind that you cannot see, but having in mind that below the leaflets, there are some cords. And you need to make sure that your implant is going to respect the symmetric distribution of cords to obtain the best outcome. Now, this is done using 3D echo, and 3D echo actually allow us to, to find the ideal orientation, what we call now in our practice, we say the clocking of the device. You have to clock the clip in order to align to the, be perpendicular to the line of coaptation. Now, to do this, again, is interesting. You need to understand that we are collaborating on the table, and so look at this procedure. Now, let's focus on the 3D echo, and you see that there is a clip opening at the moment. There is some shadowing because the probe, the echo probe, is behind the delivery system, so you have some shadowing. You don't see really well the mitral valve as you can see it without the device in. But obviously we can help. We can move our catheter, medial or lateral, and try and start to obtain a better view of the mitral valve, like this one. You see, if you move medially, laterally, now you identify the commissures. You identify even the trigons, and then you have a clear understanding of the orientation of the clip relative to the line of coaptation, and that is a key element. Have a good visualization is fundamental in surgery as well as in a transcatheter edge-to-edge. Then the final step is once you get the clocking, once you are coaxial, once you have a trajectory which is as linear as possible, then there is the magic moment of the grasping. And this is not like fishing. Absolutely not. The leaflets are very easy to be grasped. If you are coaxial, if you are well-oriented, it will be absolutely a maneuver under control. And today with with independent grasping, we can improve the amount of tissue that is incorporated into these clips to improve not only the early efficacy of the procedure, but also durability. Obviously, the more device, the more leaflets in the device, the more durability. Finally, and not last, remember, the transcatheter edge-to-edge repair, just like in surgery, is a compromise between MR reduction and gradients. You can induce gradients, so you need to be careful. And we learned, very importantly, that you should always measure the LA pressure. This is a great advantage, again, compared to surgery, because we operate on hemodynamics which are online. So we can actually assess the outcome immediately as we implant one clip. So for each clip, we make a very deep assessment of the hemodynamic result, and we look at color, but color is not giving you any disease, any symptom. The symptoms come from the hemodynamics. So having hemodynamics is probably more important than having a echo guidance for taking decisions. Again, in conclusion, and that is also an invitation to Milano, we have established now the Alfieri Bootcamp, because we should also not forget our master, Professor Ottavio Alfieri, still working with us. We start now in November the first Alfieri Bootcamp, 3 days where you can see Alfieri edge-to-edge for mitral and tricuspid, endovascularly, endoscopically, and with transcatheter procedures. Thank you very much.
Thank you, Francesco. I think we have time for a very brief question, but very practical. For me, sending patients to have the mitral valve repair, you have shown an 80 years old gentleman who would be candidate for surgical repair. We know that you have 20 years outcome of conventional mitral repair, but you had the feeling that that valve could be effectively repaired even by transcatheter. So for us, if that repair, I understand that you can sort of imagine a step-by-step approach in the sense that I can offer something less invasive, safe, and if it's effective, that's it. Otherwise, I can go back, operate on that surgeon. Is this something reasonable to think about? And what is your message within what span of time you would reconsider surgery feasible in that specific patient?
So if a patient is operable, obviously, first idea is what makes sense. 80-year-old, 82, whatever, with an ideal anatomy, I need to give a surgical-like outcome. And obviously, I know that this patient has a life expectancy which is no longer than 7-8 years. And that is a great solution for an endovascular procedure because this patient will recover the day after the procedure goes home. When you have few years to live, I don't think you should spend any time in a rehabilitation hospital. So that's the background of this. Obviously, if something goes wrong, and let's go a bit more aggressively. Let's say he comes 65 years old, which doesn't happen, but let's imagine in 10 years' time, comes a 65 years old person who has a life expectancy of 20 years. And let's imagine we don't do mitral clip only, but we do mitral clip and annuloplasty, so surgical-like approach. And imagine that maybe the leaflet detached after 3 days because I was stupid, I didn't see well, and the clip was not in the right position. Now, in this case, when you push the limits, my practice, when we push the limits, a bit younger patient, operable, I always say we try this way. If it doesn't work, come back within 1 month. Because in 1 month, then you have the reaction, which is going to create a bit of difficulty to reoperate. Obviously, if they come back after 1 month, after 6 months, this is not a tragedy. This also has to be said. I call it Alfieri square. So I leave the clip in place, I put an annuloplasty, put some sutures, and the patient can still be repaired without the need of replacement in many cases. So we should not, it's not the devil, this procedure. It is an option. And we are learning how to deal with this. I think we need to change. As surgeons, we need to understand that the population is changing. We are going to have a new nosology, a new disease, which is a patient with an implant. So, for instance, at PCR London Valves, we are organizing a session on how to deal surgically with a device that has to be explanted. So, understanding the tools and the technique to explant a device. So overall, we need to be prepared for a lifetime management where surgery and interventional procedures are combined and working somehow together. Nobody knows how, but this is the way for the future.
Thank you.
Yeah, so in other words, anatomy does matter. You must know if this valve is feasible for good repair transcatheter, as you expect surgical results with zero or really mild, trivial, residual MR. Also, experience is important to have such good results and to push a little bit the limit, let's say. But, you know, what I would like to ask Francesco Maisano, probably is not the best person because he has done, how many TEER you've done so far?
How many mitral clip?
Yes, mitral TEER.
Mitral repair overall?
No, I'm talking transcatheter.
Transcatheter is about almost 2,000.
Yeah, so he's not the right person to ask him. But what I would like to ask you.
Do one more.
Yeah, we've done 70, and so we're still climbing the learning curve, let's say. But what I would like to ask, this is a surgical meeting, and you know, after we started our mitral clip, our TEER program, after maybe 250, 30 towers, so we already had some experience with catheters and wires. And even at that point, I was still thinking that, the transseptal puncture, this is going to be really, really difficult. And then it was surprising. I don't want to say this is a stupid thing. I'm not saying that, because you must know how to do it to be safe and efficient, as you said, so I'm not saying that. But anyway, it was surprising to me a little bit, because I was expecting a much more difficult procedure in the end of surgeons. After all, you have 4 views, and, technically for us, this is not a difficult thing. So I'd like you give your perspective to these surgeons here about, this can be done by surgeon. This should be done by surgeon, because at the end of the day, you end up, and we do the same, in a very good situation. You can choose between one or the other without any kind of bias. And I think that's very good for patients, and that's very good for yourself, for your team, for the surgical community overall. So let me have your thoughts about this.
No discussion. You are totally right, and there is an important consideration. Mitral clip, or let's say transcatheter edge-to-edge repair, is not an endovascular procedure by definition, because we are not in the vessels. We are in the left atrium. It is a 3-dimensional space where we use a robotic system. So basically, it's an instrument which is similar to a minimal invasive forceps, which is long. Okay, it doesn't go through the groin, but it's still the same thing. So it is surgery. The bad news is that surgery is waking up 20 years later. And for 2 reasons. One, because we still demonize the Alfieri repair. It's a bit, I am from Alfieri, and I understand why me even, have been demonizing this procedure. Too easy. It doesn't fulfill my ego of repairing and being close to God. It works. The reality is that at the end, it works. So there are some cases where we apply first-line option. In my practice, I have no problem in a patient with a very large valve, with a very degenerate Barlow's disease, a lot of tissue. There's nothing wrong in putting a suture in the middle, nothing wrong. Annuloplasty and suture in the middle, and that's it. We don't even watch the echo, because it's going to be, for sure, a good result. So there is a value behind this idea, which was a bit crazy at the beginning. There is a value, and this value now everyone sees the value in the endovascular approach. And if you master the concept of Alfieri technique, and that's why I wanted to establish this Alfieri bootcamp, because it goes beyond the joining leaflets. You have to understand you are creating this compromise between MR and stenosis. It is true. That is the key element that we need to understand. You need to understand the importance of symmetry. You need to understand the importance of patient selection, device selection. So it goes much beyond what is the simple procedure. There is a lot of brain behind a good result, and I think the brain that is in this room, people who are doing daily practice with mitral, who deals with the mitral valve, has enough brain to apply this brain to this procedure and become in the box of the experts, not in the box of the TVT registry, where there are all comers. Also, a lot of people are doing this like palliation. And that's what I don't agree. I don't think this is a palliation therapy. It is a therapy.
I think it's a long way to go. I mean, to have cardiac surgeons doing TEER at this stage, at this moment. But still, I like to say that, this is my little experience. Cannot be compared to yours, but from our little experience, this is something that can be done. So I would like to encourage everyone, first, as you are probably participating to the art teams, to know the procedure, to know the weak points of the procedure, to know how much anatomy is important for a fair discussion. It's very easy for the cardiologist to understand that the patient on a wheelchair is not feasible for surgery, but for the surgeon, it's much more difficult to understand what is the weak point of this procedure when the anatomy is not feasible. So this is something that we really have to know if we want to participate to our teams. And then second, I think it would be great that if we do more, and I think this is possible. This is our little experience showing that, and yours is bigger, of course, But that's why I wanted to put this session here to talk about these subjects.
Okay.
Yes,
we
please.
have just one short comment. Most of the cardiac surgical departments do not have access, of course, to this technique. So I really like your message, and both of you, to get involved. Can you comment on the add-on value of knowing imaging for TEER for the cardiac surgeon? Because I think this is also a very, very important point. If you understand the imaging which you need during the TEER as a cardiac surgeon, then you have an add-on value on your own practice, whatever it is.
So imaging, very simple. Let's simplify. We need to simplify things. Imaging is 6 views. You have 3 views for transeptal, 3 views for the procedure. 3 views for transeptal is bicaval view, short axis at the base, and 4-chamber view, where you get the position of the transeptal. Once transeptal is done, the next challenge is to have an X-plane with the intercommissural view and LVOT view, and that's it. You only need 3D for clocking, and then it is absolutely simple. The imaging is simple. What is more difficult is to understand what is behind the imaging, and that is something that we are used to because we see the imaging prior to the procedure. Then we do endoscopic, or we do sternotomy, whatever we do, we see the valve. We understand what an image relates in terms of anatomy, because again, we know that there is a papillary muscle, there are cords, and the reason why A2P2 is easier is because we know how much space you have behind that image. So imaging is fundamental, is a different way of operating. You are not watching directly, it's like a transition. Sternotomy, you watch. Endoscopic, you use the camera. And now use the 3D echo.
Yes.
Same thing.
Thank you, Francesco. I think you have to do some work in our OR's. Patient is waiting for you, and I think we can connect to the hospital, in particular to Michele Galeazzi, who will present the case, the surgical case we have this morning. Alessandro, can you connect with the case presentation?
Can you hear me?
Yes, we can, Michele. This is the surgical case, correct? Yes.
Yes, correct. This is the patient from OR number 2, which is a 68-year-old man who is affected by a severe rheumatic mitral stent insufficiency associated with a mild tricuspid regurgitation with annular dilatation. He is symptomatic for dyspnea and also had one single episode of atrial fibrillation, but has always been on sinus rhythm after electrical cardioversion. Coronary angiography was performed to rule out any significant coronary disease. And now I'll show you the team working in the OR. And I think now we are ready to go to the OR.
Thank you. Let's go to the OR, Alessandro, please. Yes. Hello, Utz.
Hello, morning.
Good morning.
Back again in that beautiful OR. Yeah, I'm fine. Back again to that beautiful OR setup here. And if you see that that's a young male patient, I think the patient is already introduced. And I make a little draw to find the right height of the access routing. So can we go for that camera, please? And I make a line, this the draw, the pencil.
Explain us the drawing, Utz.
Yeah?
I see also a couple of tattoos over there, yes.
Yes? Beautiful. So please stop talking now. Yes, okay. That's the whole sternum, the entire sternum, and important is without the xiphoid. Then find the middle point going vertically down, and in the cross-sectional area from the anterior axillary line, that is a beautiful insertion for the mitral valve. If you move this in that way, it's more mitral and tricuspid, and that way it's more aortic or aortic mitral. So I think for that patient, based on the CT scan, we go in the fourth intercostal space. So, can we start?
Utz, tell us the plan. What are you going to do?
I would like to go for the incision and open the chest now.
Okay. So we're going to do a mitral valve replacement with a tissue valve mitris, and we're going to tricuspid annuloplasty, and I
But
think
Marco, I think we have to discuss this because in the TEE, can we show the TEE now?
Oh yes, we have to see the echo.
Huh?
We have to see the echo. Sorry, can we go to the echo?
Okay.
You can start, Utz. You can start. We can see you, picture in picture. Fabio, would you show us the echo?
Yes, yes. Can you hear me?
Yes, I can hear you very well. Please.
Okay. Good morning to everybody. Let me start by thanking Marco for the kind invitation to this outstanding Congress. Let's start the TOE with a 0 degree, which shows a mild left ventricular dilatation. The left atrium is severely dilated, and the ejection fraction is about 55%. You can see mitral valve leaflet that are thickened, and the motion is restricted. From a functional point of view, there is both stenosis and insufficiency. There is a long axis view. You can see the doming of anterior mitral valve leaflet and severe mitral regurgitation with a jet quite central. This is a 3D MFAS view. The posterior medial commissure is fused, there is a fusion, and the mitral valve area, here is the true view, is measured about 1.1 centimeter square. The mean gradient, the mean mitral gradient is 6, but it may be underestimated due to bradycardia. As Professor Kapper asked, the tricuspid annulus is about 4 centimeters, and you can see that tricuspid regurgitation is mild. Can you stop just a moment, please? The tricuspid regurgitation is mild, if any, but the annulus is dilated about 40 and 21 millimeter for square centimeter. That's all. Thank you.
Thank you. Thank you. Yes.
Yes. Okay. Great. So I was talking to Utz, and we were discussing this case. And maybe we can make a vote in the auditory. What do you think? Should we do the tricuspid as well or not? Because actually there's no regurg, and
There's nothing
the annular dimension is 3.99999 centimeters.
Yeah.
What do you think?
What do the audience think? Would you repair this tricuspid valve? The audience. Who want to repair this tricuspid?
Stop ventilation, please.
What? Who would repair the valve? So I think 20%. Don't be shy, please. Jörg.
Who would not repair this valve?
Not repair. Jörg.
Actually, this would be our plan, but it's a democratic decision.
No, there's not a democratic decision. It is a question of indication. And so I discussed this yesterday with Marco, and we spoke with the patient. So the patient is informed that we go for a mitral valve replacement and for the tricuspid. So, but now, and after revisiting all the facts, I would change my indication in direction of the tricuspid and would go not for a tricuspid repair. But I would only do this. Correct me,
Utz, correct me if I'm wrong, because this is we are under anesthesia now, so the amount of the regurgitation might be a little bit underestimated. And how was the tricuspid regurgitation on the transthoracic echo?
But
Fabio.
But Marco, we also need to, we had Francesco a minute ago, right? So I think what we also need to discuss more in the audience, I think it's the critical point, it's not I mean, it's a lifetime management thing. So we know the data from the randomized trials, tricuspid repair, yes or no.
Yeah.
And we know that the pacemaker rate is not 0. It's more in the 20% range, especially if you do it cross-clamp where you don't see the AV block happening. And we had Francesco a minute ago embracing also new technology. So the reason why in the past we always try to do prophylactic repair is because we don't want to go back for redo surgery. Now we have new tools. So it's a mitral stenosis, meaning if you relieve the mitral stenosis having an annulus of only 40, most likely this patient is not going to develop tricuspid disease. And if it is happening, then still 10 years down the line, these days we have new tools like edge-to-edge tricuspid, a cardioband, and all these things to fix it in a minimal invasive manner, which was not feasible 15 years ago when Jill Dreyfus and all the other hammered on the prophylactic repair. So my personal opinion is less than 40, I would not touch it. 45, sure, you need to do it for prophylactic indication and also take into account that mitral stenosis. So it will see a significant hemodynamic change. So I would definitely not do it, but it's open for discussion.
Yeah, I think, Corrado, please, Alessandro, if we speak in the audience, please mute the OR, otherwise there is no way to make any discussion here. So, you want to say something? Because also Antonis, I see that we are, the discussion is coming. You know, I don't agree 100% with what you've said, Jörg, in particular with the fact that we should, you know, rely on possible transcatheter treatment on the tricuspid in a few years.
You know, in the United States, in February, just a few months ago, transcatheter Evoke was approved, and the trial is amazing. There's almost 0 tricuspid regurgitation at 95% of patients. So in 10 years, it should be fantastic. I think the most important thing here is the fact that the patient's got a mitral stenosis case. And the tricuspid valve is 0, and it's going to be less than 0, you know, after they fix it. So I kind of think it's nuts to fix a tricuspid valve that has 0 tricuspid regurgitation in a mitral stenosis case.
It would be interesting to see the data on which the Evoque was approved, you know, because so far they have been published only the single arm. And so, as you know, Joe, you are much more expert than I am, but complications of that trial in terms of bleeding were so and so. So before spending the Evoque on this patient, I would be, I understand.
10 years from now, yeah.
One thing I would like to comment, so I don't want to play the advocate, or the devil's advocate now. I think we have to consider one thing, and this is atrial fibrillation. This changes the whole decision-making, in my perspective.
He had one episode. He's on right in sinus. He had one episode.
Sinus rhythm. If this patient had a chronic atrial fibrillation, then I think we had to seriously consider it. One thing I would like to point out is that this decision making should be made the day before. So we all have to know the data of the previous echo, because what we see now is just a, you know, it's like trying to reading a newspaper in the rain. So decide before. Now having all these things, I would also not consider doing the tricuspid valve now, but this is a decision that we have to make yesterday.
Excuse me, we discussed about tricuspid, but no one touched a word about defibrillation. Why would you do the tricuspid and not treat the fibrillation? He had one episode, you told us.
He had one episode. His left atrium is 48. He has a severe mitral stenosis that we're going to fix. So, Antonis.
I think if I was, how old is the patient?
50-something.
50-something. So he's a young patient. So if I was in the place of this patient, I would certainly not want to have a tricuspid repair, because the risk of pacemaker, as Jörg said, is 15%. And I think for a 15 54-year-old patient to have a pacemaker is devastating for a prophylactic repair. On the one hand, without any sufficiency. If I was having moderate insufficiency...
He had mild to moderate, I think,
when he was awake.
On transthoracic, when he was awake.
When he was awake. But if he had moderate now, yes, I would repair it. With zero insufficiency, I wouldn't go ahead and repair it.
So let's say it again. It was mild to moderate on awake. Pulmonary pressure was 40...
Or 50 or whatever.
40 something.
Yeah.
Also, left atrium is dilated.
Yes.
48 milliliters square.
No way I'm going to repair this valve because I think if we cause any complication, then we are totally unjustified. We don't have any evidence to support the 4 centimeter and things like that. I think this is something that we have to review. But apart from that, the one episode of AFib is rather important, and this is a mitral stenosis case, and there is fibrosis in the left atrium. So I would certainly go for left atrial maze. I wouldn't repair the tricuspid.
For one episode?
Yes, for one episode. Yes, this patient needs the box. The box is mandatory, and I think, I mean, we are open. We're going to do the isthmus and the coronary sinus line as well. We don't want to end up with left atrial flutter. So I think not tricuspid repair, but certainly left atrial maze.
Totally agree.
The clip, yes. Michele De Bonis, I'd really love to have your opinion about this case.
Marco, can you hear me?
Yes.
Well, great. So we had some microphone issues, but okay. Because I just wanted to comment something on the procedure. So, the transaxillary is a strictly standardized procedure, and we have some steps. So just to conclude, so the first step was to open the chest at the fourth interspace, which Utz did. Next step is to place this soft tissue retractor. Then we were looking whether we are on the right height. So if you see the pulmonary vein, you are not wrong, I would say. Then Utz was removing the pericardial fat and opened the pericardium. Meanwhile, we disconnected the lung and we are completely full on pump. And Utz is now doing the pericardial stay sutures. These stay sutures are quite essential just to bring to pull this operative field towards the chest wall. And usually you make 3 stay sutures, and he's stitching it like, as you can see, some everting stay sutures. This is quite important, just to bring the operative field towards the chest wall. We place 3 on the upper margin and 3 on the lower margin. And this is actually where we are at this moment. Next step will be to mobilize the SVC and to place a traction suture in the interatrial groove just to prepare for the atriotomy.
Excellent, excellent. And this is moving all the heart. I would open the pericardium a little bit higher, but I learned this from Utz, so I cannot say anything. But Michele, you were saying something.
Yeah. Yes. Well, my opinion is that this is a young patient. I would not assess as you say.
Michele, sorry. Can you mute the OR when we're discussing in the hall, please?
Yes, thank you, Marco, for asking me. This is a young patient. I would not assess the tricuspid valve in theater. I would just rely on preparative echocardiography. Preoperatively, this is mild to moderate. There is a history of atrial fibrillation. There is mitral stenosis. The likelihood that this patient might still have, let's say, a rhythmic problem in terms of atrial fibrillation in the future is not low. There is some degree of pulmonary hypertension. The annulus is already dilated. So first of all, of course, I would replace the mitral valve. For sure, I would treat the atrial fibrillation. At least the left maze, I would do that. I would exclude the left atrial appendage. And as far as the pacemaker complication, which is worrisome, reported in New England Journal of Medicine, 15%, which, to be honest, is not that common in, let's say, common practice. I think that is also because we are considering as the only possibility to treat this valve to use complete semi-rigid ring. This is a technical issue we are underestimating. I mean, rings, the semi-rigid rings force you to put stitches until the end of the ring, because you cannot leave the ring without stitches, isn't it? Otherwise you have adhesance. But if you do, as I tend to do in this situation, if you use a flexible one, or if you use what I've been discussing for 20 years with Manuel Antunes, who was telling me, Michele, I never reoperated a patient with when I did a D Vega modified according to my technique, which basically is to put a pledge at any time you come out with the suture. So you get at the end a kind of flexible band. The advantage of that is that you can stop your suture not where the ring forces you to go, you can stop the suture much higher. So in that case, I never had one pacemaker implantation because you can stop earlier. So why you should put necessarily in this setting where we are discussing about doing probably nothing, a complete semi-rigid ring. You put a band, you put a modified, full of pledged suture, you stop earlier. Pacemaker should not be different as compared to the mitral valve replacement alone, and you provide the patient a stability of a disease where atrial fibrillation, pulmonary hypertension, rheumatic disease are risk factors for progression. That's my idea.
Can you hear me?
Yes, we hear you.
So I think there is quite strong discussion about what to do in this patient, and apparently also treatment of AFib is something that should be done. Would you agree? Yes, yes.
This patient has a huge LA, so that means for me, I think it is 48 millimeters per square meters body surface. So that means the left atrium is nearly 8 centimeters in diameter, and so cut. For me, I think that patient had only one time the paroxysmal fibrillation and was converted, and it is now on sinus rhythm. So for me, only an occlusion of the left atrium makes sense, but not an cryoablation in that big left atrium. What do you think, Marco?
Okay, I think we go this way. This is what we've been discussing with the patient yesterday. We were happy with this final decision, so I think we stick to the plan. I think it's good to do this.
Yes. Manu.
Antonis, can we give the mic to Antonis? Pizzis? Oh, you have it, please.
Again, I'm going to disagree, Marco, because left atrial diameter is not a contraindication to MACE. We know that. I mean, this was proven by Nivad's team, you know, and we have done this study. It is not a randomized trial, but we have very, very good evidence that when we have large atria and we are in sinus rhythm, this is not a contraindication. We can have giant atria, and this is not a contraindication.
Okay, Antonis, but you know, it's Utskapert on the OR. And we're doing live surgery.
Talking theoretically.
So, okay, yes.
I'm talking theory. Yeah, okay. Obviously, which is going
so
to
I think we should
whatever.
remain a little bit...
to stick on the plan.
Yes, please.
But, yeah, okay. Fair enough.
I think no matter what you do, this patient will have AFib. Let me tell you, whatever you do. And so we can do it. We can put the clock a little 1 minute earlier or later, but this patient is going to have atrial fibrillation. And this is the reason why some of us push a little bit toward the TEER repair. It's okay with what...
You want to explain this better? What you mean? Some of us
just for the discussion, I totally agree with you that in some time he will have AFib, but the later, the best.
Ja. Nico? Wo ist dieser verdammte Kerl?
Do we have a plan about the left atrial occlusion? Should we do we have a plan about the left atrial appendage occlusion? So it's going to be closed.
Okay.
Pass mal auf, willst du vielleicht mein Mikro abmachen?
Utz, maybe, Utz, Kappert, Maybe you call us when you have the aorta clamped and you expose the mitral valve, okay? And maybe we can proceed with the presentations, okay?
Okay, yes, sir. I agree. Cardioplegia? Cardioplegia line.
Please mute the OR. So when we're talking here, please. So it's my privilege to ask Joe Bavaria to get the podium. He's going to give us an update on the STS-ACC-TVT registry on mitral therapies, transcatheter, catheter-based. Thank you.
Yeah, thank you. I think the main thing about this talk is going to be Francesco Mazzano's comment that this is a relationship between mitral stenosis or gradient and mitral regurgitation. So this is from the TVT database in the United States for TEER, and I was the TVT chairman for many years. This slide is just a quick slide on the aortic valve. Just I thought I'd show that the fact that TAVR has now surpassed aortic valve surgery in all of its forms in the blue line back in 2019. And this slide will be updated in a few weeks, actually. These are my disclosures. For TEER and the TVT database, there are 831 sites in the United States. There's one site for every 60,000 people over the age of 65, which is now more than any other country. The TVT database has multiple modules, and the TAVR module is the most important one, but there's also the mitral clip and the TEER, as well as mitral valve and valve. And it's very important to understand that the TVT registry is government mandated, so that you simply cannot do a transcatheter operation without entering the data into the TVT registry. So it has 100% participation because you cannot get paid money. You can't get paid without being in the database. So science tells us what we can do, guidelines tell us what we should do, but registries tell us what we're actually doing. This is an important concept. So the volume data is for TEER. There are 542 sites in the United States doing TEER from the TVT database compared to 850 or more for TAVR, so it's about 2/3. And it's not as active as TAVR. There are over 90,000 TEERs in the registry as of 2023, and 15,000 expected or more this year, last year in 23. Now, just like Francesco said, the median age for TEER in the U.S. In the registry is still very high, 79 years of age. It doesn't seem it's not migrating into lower age, at least yet. We'll get the 2023 data very soon, though. So it's an elderly population. Now, this is interesting. The mitral valve disease etiology, as you can see in the red arrow, in 2019, mid-2019, TEER was approved for secondary MR as well as primary MR. And you can see in the red bar that the percentage of functional MR is going up. And it's now 54% degenerative and 35% functional MR. Now, what about the outcomes, real-world outcomes? This is an important slide because this is an all-comers slide. This is 15,000 cases a year, and what you see here is that there's no real improvement in gradient. So this is 23% of all TEER cases in the United States have a gradient of over 5 millimeters, either greater than or equal to 6 millimeters. And the other issue is that it's not really changed much over the period of time. So this is what Dr. Mazzano was talking about, between the balance between whether, a question I wanted to ask him was how many patients actually have no MR and have less than 5 millimeters gradient. That's the kind of the key question. What's the percentage? Because that's a perfect TEER patient. Now, so that's an important slide I just showed. This is another important slide, which shows that, and I think it was exactly what he showed from EuroPCR, that about 7 to 8% of patients will still have moderately severe or severe MR after TEER. So this is a bit of a problem. This is probably not so good. Surgery certainly would be better than this. So this is the balance. The mortality rate, though, is incredibly good. This is a very safe procedure, and there's never been any doubt about it. The 30-day mortality is 3.3%. The in-hospital mortality is 1.5% in the United States. Now, because the patients are 79 years or 78 years old, you can see in the green bars that the one-year mortality is a little bit high at 20%. So maybe we're operating on some patients that should be treated medically. So the stroke rates also are very low. Let's see if I can go back. Yeah, the stroke rates are very low with TEER, and we're extremely pleased nationally with this data, as well as the mortality data for this procedure. The change in New York Heart Association class is also very satisfactory. As you can see, most patients are in class 3 or 4 baseline, but there's almost none of them in class 4 and very few in class 3 afterwards. Now, the only problem is, and this is with the database, is that 41% are not documented afterwards in the database. This is one of the database problems that we have to solve. So I'm not happy about that. Median length of stay is now down to 1 day in the U.S. So again, the operation is very safe and efficient, and does, from that standpoint, is very, very good. So real quick on transcatheter mitral replacement. This is replacement of the valve. As you can see, there's 410 sites now doing transcatheter mitral valve replacement, valve and valve. But it's a little bit flat in the last 2 or 3 years. Now the Lampoon procedure is concurrently performed with TMVR in 12% and growing every year. We'll have to see what the 2023 data looks like. Again, just like TEER, the median age for transcatheter mitral valve replacement is 75, which is still quite old. This is the reason why, and these are really sick patients. So you can see that the blue line and the red line are extreme risk and high risk, and most of the patients are extreme risk or high risk. So these are very, very high STS score patients for transcatheter mitral valve replacement. Now, this is the most important slide in this thing. This is why this procedure may have some fundamental issues. You know, this whole valve and valve issue is going to have to be resolved at some point. So this is looking at a mean mitral valve gradients after transcatheter mitral valve replacement. And again, it's an old patient. These are sick patients. I understand that. But this may not be able to be relegated to lower risk patients. And here's the reason why, is that 70% of patients have a mean gradient over 6 or over, 6 or higher. That's the vast majority. So it's almost impossible to get a patient with a transcatheter mitral valve, valve and valve, to not have a significant gradient. And so this is an important point. Again, very high gradients, no improvement over time at all in the whole 10 years. But on the other hand, my transcatheter mitral valve replacement is incredibly good at MR. There's basically no mitral valve insufficiency in these cases from the database.
Joe, I'm really sorry to interrupt you. We have to go to the live surgery for 1 second. Do you mind? Can we go to the OR, please? Yes, we are with you, Utz.
Yes. Okay. So the following: we are cross-clamped, and maybe Utz has done the left atriotomy, and maybe this is a special thing which is different to, I think, to the endoscopic approaches. The atriotomy is more done towards the roof of the left atrium, and not to the not below the vena cava inferior. So maybe this is a little bit different. So the angle is you come more from above. So now we are with the last minutes of the cardioplegia, and then if the
Can you explain this difference? I mean, as you notice this difference, will you make some arguments on it?
Yeah, sometimes you have this this fold on P3 blocking your view. I would say because the angle of view is a little bit more rectangular to the valve. I personally think that you have usually a very good exposure of the valve for the surgeon. We will see. We will see. So
we will see. Yes.
Much, but we will see in some minutes.
So what is the plan? What's the plan? You going first to do the mitral or manage the left appendage? We can't hear Utz Kappert, please. Can we the microphone?
Okay, I translate. So Utz is using the forceps as a lever. It's just manipulating the left atrial appendage, and now he's opening the left atrium just to make this big enough to pass through the valve and expose the valve. And I think, yeah, he's going to manage the left atrial appendage before the mitral valve. I think so.
Okay.
We'll see.
So maybe you want to put a sucker into the left atrium to have a bloodless field, yes. I imagine.
Yes.
Here it comes.
Here it comes.
So, Manuel, can you anticipate, are you going to expose the left appendage and the transverse sinus?
There are two ways. You can go above the aorta, which is, I don't know, I think there are some German publications who call it the North Pass, but I don't know how to translate correctly. And actually you have two ways. You can go through the sinus transversus or above the aorta. So I think it's from case to case a little bit different. I would say just choose the way which fits the patient's anatomy. So we have both options.
But I see you going to the mitral first. I understand you were doing the left appendage first.
Yeah, that's maybe I think Utz will show the mitral valve.
Going like this.
Willst du den Clip danach machen?
Ja, warte mal, ich will.
Okay.
I want head it. Hold it. Yes.
So can you see the valve? I think, huh?
Yes, and I can tell that this is the head camera view. This is not the eye vision, of course, which is still which is even better, of course. So I think from this camera view, head camera view, you can appreciate basically the trajectory to the valve and how close that is, and again a very good ergonomics, hands and eyes. So you really, eye view is better. I think this is more than enough for the team in the OR and for us to follow what they're doing. But eye vision is 3D,
so Marco?
4K. Yes, let's go to do the appendage.
Yes. So we just had a short impression of the mitral valve, and I think we are the mitral replacement strategy is absolutely correct in this case. So you saw it, and now we are going to search the left atrial appendage. Usually you look for the tip of the appendage. You place a traction suture and use this to just to place the clip over the appendage. So.
But you're going to put the clip into the transverse sinus, or you're going to do it from the pericardium? I mean, because
so it's just going over the aorta.
Over the aorta.
Oh, here we are.
This is new to me.
Yes, Utz has the.
Okay, Manuel, can you tell us something about the device you're using?
Yes, this is the AtriClip Pro 2, which I think for closure of the atrial appendage in minimally invasive manner is perfect, because the holder has a U shape. So after you delivered this, after you release the clip, you can just pull back, and you do not displace your clip with the holder. This is a difference to the, for example, the Pro, which has a circular holder on the tip. So this clip you're having here is perfect for this. So, and now as you can see, Utz is placing a traction suture through the tip of the left atrial appendage, and then he's bringing it through the clip and uses this as a guidance suture for the.
Manuel, let me ask you one more thing. I mean, you're always going to reach the appendage from this upper northwest, let's say, route, or you're doing something, because I imagine sometimes the appendage cannot be that big, and probably it's more difficult to get it. But just tell me your practice.
Actually, I would say it's 50-50. So
50-50.
We use the way we better see it.
Okay.
So, but in this case, I think the exposition of this appendage is really nice. I think it's important to flex this clip a little bit by 45 degrees, that you really place it on the base of the LAA.
Mm-hmm. This is
so
new.
Now the clip is placed.
Tension, that means tension.
Dann vorne gibt es so einen Knopf, den orangen, das muss er machen eigentlich. Wenn du mit der Pinzette hältst und can you just release the clip?
And what about sizing?
Actually, we had a CT. We sized the collar of the LAA by CT scan, and this is a 35 millimeter clip.
Okay. We do not size because we have empty heart, so there is no reason. So I think this device was designed for beating heart procedures with heart is full. Now it's empty, so the small one, they always go well in our hands.
Ja. Der ist nicht gelockt. Der ist nicht gelockt. Ja, genau. Jetzt vorne den Orangen. Dann loslassen und hinten das Orange rausziehen. Ja, genau. Und dann nur genau. Und dann einfach zurückziehen. Yes. So the clip is delivered.
Okay.
And usually we, during the mitral surgery we can check from the inside if the position is well, but this was good to see right here. Yes. So that looks nice, and now we come to the main part of the procedure, and Utz is placing the retractor and exposing the valve.
Come on, Utz, you have 1 minute to expose the valve. Not more. 15 seconds.
Yeah, now it's coming.
I know.
So, and as you can see, of course, it's the camera picture, but the direct vision, the surgeon's view, is directly rectangular to the plane of the valve. So it's easy to see, and
yes.
maybe you can discuss this, or we discuss it later. Maybe this is an advantage of this direct vision approach, that the type of surgery at the valve is not different to a sternotomy approach. So you do not have to relearn or something like this. So, and you see, Utz is using a standard forceps. So it's a very easy to adopt technique. So I think Utz is going to cut out the valve, because of these calcifications. There's less option to preserve parts of the subvalvular apparatus, so I think it's more consequent to cut it out, especially in the anterior part right here.
Mm-hmm. I see you using very conventional instruments without even the loops.
Yes. So this maybe is an it's an advantage, I think, that you can do this procedure with 3 instruments. You need a long forceps, long scissors, and 1 endoscopic needle driver. So with this, you can you come a long way in this procedure.
I think this is very important for countries that they do not have access to very expensive instruments and equipment. I like that this is not depending on technology. I'm not saying we don't have to push industries to develop new technologies, but still it's a good point that we're not depending on technologies.
So I think what you say is absolutely right. The setup is quite simplified. Huh? So you do not need many fancy things to perform this procedure in this way. So
yes. I think if you don't mind, I don't know if Alessandro can put a little picture from the OR in the Joe Bavaria presentation that can continue. You can continue. It's almost. Yeah. It's okay. Yeah. It's okay. It's okay.
Okay,
so
maybe this is a perfect idea. So we're placing.
So maybe we can have a little discussion about the Joe Bavaria presentation while we can have the images from the OR going on the main screen. What do you think? Alessandro, can you do that? OR on the screen and a little bit of a discussion.
Joe, if I may, you have shown us that definitions are very important. If you look at prosthesis, for example, when you want to define prosthesis failure or malfunction and so on. So do you think the societies should work on TEER in terms of success as you are doing, in terms also of volume? Because I think this is another important issue. And on center volume, you have shown in the past that mortality and volume are strictly related, and in terms of repair, also volume and success. Would you comment on?
Yeah, I mean, if you did the math, you could tell that the average number of mitral clips was, almost like 10. If you look at, so there's a lot of programs that do very few, and then there's a lot of programs that do a lot. So this is the TVT is a snapshot of the entire country. So it's reality, and it's important to remember that it's 100% participation. So it really is incredible database. Because again, if it's not about the money, it's about the money, right? So if you don't put your patient in the database, you don't get paid. That's why that's the power of the database. But the fact is that we have shown in the database that there is a volume outcome relationship, and it's about 35% better. If you're a big versus a smaller place. So the volume outcome relationship is real, and it's real not only in mortality but in morbidity as well. So outcomes. So I mean that's the answer to your question. Now the government through the societies is placing some restrictions on new technology applications. For example, a transcatheter tricuspid valve approval is probably only going to start in the first 3 years in places that do more than 20 mitral clips a year. So it does play a role, what you're saying.
Okay. I think we can go to room number 1, but we can go to Michele for the TEER patient presentation. Alessandro, let's go to Michele for case presentation. of patient number 2.
Okay.
Va bene, perfetto, perfetto. Okay.
So, our patient for the transcatheter mitral valve treatment is an 80-year-old man who presented for dyspnea on exertion with a New York Heart Association class of 3. Echo evidenced severe degenerative mitral regurgitation due to a P2 flail. He has no relevant comorbidities apart from a moderate chronic kidney disease and has a Euro score of 2.73%. So this is the team working in OR with Professor Maisano. I think we might go to the OR now.
Alessandro, can we go to room number 3? I know I have this one, but...
Okay. Marco?
Yes.
Yes, okay. So the valve is cut out. Maybe I think you have seen this picture in picture. And now Utz is placing the valve sutures.
Yes.
You know, maybe you can discuss this with the auditory. We prefer these stitches from the atrial side. We think it's less risk of atrioventricular displacement and less risk of CX occlusion. But you know, there are always different opinions. What do you think? Maybe you can ask the auditory.
We do I do the same.
What's the most preferred?
Who is going inside, outside, from ventricle to atrium? Right hand? This is 5%, 7%, 8, not more than 10. But I think you want to make a question? No. Okay.
Yeah,
so I think while we wait for Francesco, we can move to the next session, and I'd like to invite the next moderators to join me here. Tu c'è la reazione? Sorry. No. I'm wrong.
Okay.
Sit down. I'm wrong. No. You cannot jump this one. Francesco Grigioni. Sorry. Transcatheter and surgical mitral valve intervention, expectations and reality. Please mute the OR.
Okay, thank you, Marco.
I'm sorry, Francesco.
No, it's okay. I will try to do the impossible, squeezing 40 years of mitral valve functional MR in 10 minutes, so something really impossible. Nevertheless, let's start in the period from 1943, when the paper on the French correction was published, up to the Everest II trial. This was a fantastic period for cardiac surgery. Nevertheless, results were conflicting, and today I would like to highlight with you some of the most relevant advances. This is one of the most iconic papers every cardiologist should read, because all of our cardiac surgeons' friends are based their knowledge on it, and basically the point is that the valve can be repaired and should be repaired. From 1980s, every good surgeon should challenge her or himself toward repairing functional mitral regurgitation as well as degenerative mitral regurgitation. But at some point, somebody came up with a technique which was reproducible and applicable, and the name of this person was Steve Bolling. Was the late 90s, where he showed that restrictive annuloplasty in patients with dilated ischemic or non-ischemic cardiomyopathy can be done. It reduces functional mitral regurgitation. Operative mortality was acceptable. Again, here there's no randomized trial, there's no medical treatment arm, but this paper made an important point saying that FMR can be repaired with undersized ring. Few years later, when they compared the outcome of this patient with patients treated medically, and once again, the treatment for heart failure was not the same as today, there was no any gain in survival. But once again, and this is the first bit of the cardiac surgery area, there was no randomized trial testing this hypothesis. In 2015, one of the big assumption of the cardiac surgery, the repair, was challenged, And again, what they found in this beautiful paper published in the New England was that replace a valve was not actually worse than repair the valve and led to a less recurrence of mitral regurgitation. This was a big slap in face of all those cardiac surgeons who thought that mitral repair was actually to be pursued in every patient. And the other important delusion which came, at least to my eyes, came in the same year, 2016, when in this another important trial, they compared in patients undergoing coronary artery bypass graft, adding mitral repair or keeping only the revascularization procedure. And this will be addressed later on by Michele De Boni, so I won't touch on that. But again, the results was not what we expected from surgeons and cardiologists taking their interest in functional mitral regurgitation, because the studies show no difference in repairing the valve. On the cardiology side, the year 2000 provided a new important, at least in my eyes, even though I have a conflict of interest, assumption, which was that even mild mitral regurgitation is associated with a poor outcome. In other words, if we look at patients with ventricular dysfunction and we compare with another group of patients, similar age, ejection fraction, and gender, and so on, even mild mitral regurgitation was associated with a worse outcome. And why is that? Because in these patients, the amount of volume of regurgitation is low, because the left atrial pressure is high, so you cannot have the same amount of regurgitation you have in degenerative, or let's call primary mitral regurgitation. Then in 2005, there was another important point made by cardiologists, which was the change of functional mitral regurgitation during exercise. 2 or 3 beautiful papers published in the New England Journal of Medicine. They show that if functional mitral regurgitation worsens during exercise, this is important in terms of prognosis. But once again, physiopathology does not apply to nowadays. And the issue of worsening of functional mitral regurgitation during exercise echo, despite a promising rise, now has been mostly abandoned. But then when everything changed, it was in 2011 when the Everest 2 trial was published. Why is that? For those younger, this was, again, a trial comparing endovascular mitral repair versus open mitral valve surgery. And to make a long story short, what they found was that conventional surgery was more effective when looking at the primary efficacy endpoint, freedom from death, surgery for mitral valve dysfunction, and grade 3/4 mitral regurgitation. But what was important was that the mitral clip procedure was safe. We can argue safer if we take into account blood transfusion, or as safe as if we take out blood transfusion. And we wrote thousands of pages at the time of this issue. But what was important was the secondary subgroup analysis, showing for the first time that TEER, edge-to-edge transcatheter, was more effective in a subgroup of patients with functional mitral regurgitation. And I think this is where everything started. Then from the Everest 2 trial, and this was again a randomized trial, we came up to 2018 when the 2 landmark papers coming from 2 trials across the ocean were published on percutaneous treatment of functional mitral regurgitation. You are familiar. The MITRA-FR, which was published earlier in 2018, showing that edge-to-edge transcatheter repair plus medical treatment was not superior to medical treatment only in patients with functional mitral regurgitation, whereas the COAPT trial was positive, showing that the clip on top of medical therapy was superior to medical therapy in patients with functional mitral regurgitation, taking into account very strong endpoint, as you can see here, hospitalization for heart failure on the left and death for hemicause. Now, this is not the place where I want to summarize the differences of the MITRA-FR and the COAPT, but basically the main topic was that if you take a patient who's too late in the disease, who has already pulmonary hypertension, extreme left ventricular dysfunction, you cannot do anything good to this patient. And perhaps the CoAP patient with an earlier stage of the disease with more severe functional mitral regurgitation. This is a paper by Marianna D'Amo showing that if you take patient above the inclusion criteria of the CoAP, I mean sicker than the CoAP patient, adding a clip on top of medical therapy does not provide any benefit. You can see freedom from all cause of death on the left, red line and blue line, those with a CoAP-like patient versus no CoAP-like patient. So once again, if you take patients too sick, the clip cannot put the clock backward. But any failure at the end has an opportunity, then every trial can be read the other way, vice versa. This is a surgical trial, one of the very few on functional mitral regurgitation, testing the core cap versus the annular surgery only, meaning that there was a group of patients treated with annular ring on ventricular dysfunction only, and what they found was that putting a ring, an undersized ring, reduced, remodeled positively the ventricle. This is a change of ventricular volume from baseline, so you have positive remodeling and improvement in ejection fraction. So once again, if you read the studies, you can find something very interesting. And this is another paper we published when I was in Bologna, showing that even in end-stage patients, those listed for heart transplant, if you put a clip on top of medical therapy, perhaps you don't reduce mortality, but you can reduce the number of hospital admission in heart failure clinic. So once again, there is no one sign only to look at. And this is, I think, one of the most important slides I'm going to present you today. These are the data from the CoAP. It's not the matter only of the patient, but it's a matter of the amount of mitral regurgitation you left after the procedure. Our surgical colleagues have shown us that if you repair the mitral regurgitation, you have to be effective. And if you compare in the CoAP patients who, after the procedure, have residual MR who was significant, red line, you can see, and you cannot see any difference between clip plus medical therapies versus clip only. So it's not only a matter of the stage of the disease, but how good you are in the repair. Nowadays, the last two slides, Marco, nowadays we know that when we talk about secondary, I like to call it functional mitral regurgitation. Atrial functional mitral regurgitation is important, was already in the papers by Carpentier, but nobody called it at the time atrial. So if you have dilation of the atrium and loss of annular contraction, you have a functional atrial mitral regurgitation, which is bad either in AFib or in sinus rhythm. Transcatheter is an option in this patient, but I do really ask our surgical colleagues to work on this subject because this is dilation of the annulus, and I think the concept must be proven first surgical. This is a paper showing that if you treat surgically on this patient, it's not a prospective randomized trial, you influence positively the outcome. So please, our surgical colleagues, do not miss this opportunity to show the proof of concept. My conclusion, FMR is bad, mild is bad, must be treated. Phenotype and treatments are very different. Nowadays, we understand much more about phenotypes, and as Francesco Maisano said, both surgery and transcatheter therapies are synergic and should help and push one each other as valuable option in different patient settings. And I thank you very much for your attention.
Great. Thank you, Dr. Grigioni. I think that you demonstrated very well. Please stay there. Perhaps we can take some questions on the value of TEER for the functional mitral regurgitation. So now, of course, we always have the discussion about the difference between ventricle and the ventricular disease and valve disease. I want to bring you to another point. What do you think about the primary mitral regurgitation?
What is, sorry?
Primary, degenerative disease, prolapse. Is it just for the inoperable patient for you, or is it something that you consider to, let's say, patients with less age?
To be fair, as you know, there are trials going on, registered, enrolling patients who would be candidate for surgery with degenerative mitral regurgitation who has now been submitted to transcatheter. But this stage, let's start with what we know. We know that mitral repair is effective. We know that surgical mitral repair is effective. We know that surgical mitral repair restores life expectancy of a patient at 20 years, and there are not many procedures that can do that. So it's a challenge. I think that nevertheless, the patients want a minimally invasive procedure. At the same time, we have to understand that surgery is not the same as 20 years ago. So we are seeing on that screen that surgery is no more the same. So today, I think probably it will come, but I would be very cautious in considering catheter in surgical candidates with acceptable surgical risk.
Okay, I think it is a very fair response, and it puts it to context that it's a life expectancy should be taken into consideration. So we move on to the OR, Marco.
Okay, and maybe we can jump in room number 3 with Utz Kappert for 30 seconds. We just see the valve, Francesco, and in 30 seconds we are there. 30 seconds, just see the valve that Utz has implanted. Yes. Utz, can you show us the valve? Which kind of, Manuel?
Yes.
Which kind of valve we have implanted here? Last view and main features of these valves, maybe you can say?
Yeah. This is a 31 millimeter Edwards mitris, and maybe the interesting thing is that it has some kind of a cinch mechanism. You know,
yes.
Some know this from the Hancock. So you can just pull together the struts to prevent from looping with your valve sutures. And now we are using core knot.
Yes.
Just I would say for convenience reasons, it would also be possible to tie this by hand. So, but yeah.
Last.
Yeah, it might be important to discuss the new mitral valve from Edwards. The Edwards company is putting resilient tissue on all of its platforms for the aortic valve, for the mitral valve, for transcatheter valves now, and even in the Connect conduit, which is the BioBental device, which should be coming to Europe very soon. And it's interesting to note that we just published the 7.7-year data set on the Commence trial from the US on Resilia at 689 patients, 7.7 years, and there was only two structural valve deteriorations that required re-op. So it seems it's still, we need 10-year data, but it seems to be a pretty reasonable tissue at this point.
What is the rate of these valves in the US? I mean, the Resilia tissue is going up like this, or?
Well, I don't really know the mitris part, but although mitris is coming up too, but for Inspiris, it's probably 70%.
Joe, you have touched, as usual, a very important point. It's interesting to see the TEER going below 65 years of age, despite disadvantages in the US.
Yeah, this is really significant.
I'm your friend as well.
Yeah, I get it. This is, we'll have to see how this happens. What can I say? 47% of TAVRs in the United States are done in patients under 65, which is
despite
crazy.
guidelines, apparently. Yeah. Michele De Bonis, I see he raised his hand.
Thank you, Marco. I want to come back to the presentation of Francesco and ask you something which I think in the future is going to be more and more common to the panelists and also maybe to the audience. I presume that in the future we are going to see more and more situations where a patient who currently, according to current guidelines, does not have an indication for transcatheter edge-to-edge repair, for instance, let's say is 62, fit, low risk, is well aware, very well informed. He knows the results of transcatheter edge-to-edge repair and surgery, but he does not want surgery. He doesn't care that's a minimal invasive approach. He does not want surgery. He wants a transcatheter edge-to-edge repair. But this is associated to higher failure rate. You will possibly replace your valve in 6-7 years, we don't know. I still want transcatheter edge-to-edge repair. What should we do? Should we
give it to him.
Should we write down in the notes that the preference of the patient is important, we will offer transcatheter edge-to-edge repair, or we should say, according to current practice and guidelines, you have no indication of this therapy, you cannot be treated?
So first, 94%, you know that 94% of the patients follow the indication of the heart team. So we should be clear to ourselves not to hide ourselves after patient's preference. They can understand, they understand mechanical versus tissue, but 94 of them follow our guidelines. Second point, I think, at least in our practice, if it's ethical, and this is ethical, I cannot judge it.
What is our practice?
In my institute,
your hospital?
in my
94, so you can...
No, what I'm saying, the literature says that in the registry that 95, 94 of the patients follow the indication of the heart team. This has been published in the study on the registry on TAVI, okay? 95%. So, first point. Second point, in the practice of my institution, in our heart team, we do what we think is ethical, and this is ethical. We cannot say, at least in my is unethical, but the patient has to sign an informed consent refusing conventional surgery after he talked to the surgeon. I refuse conventional surgery, and sign it.
I think the issue is the heart team. The issue is the heart team. If the heart team works well, patient will follow the heart team. If the heart team doesn't work well, patient is free and have more power on the final decision. So that's the point. So I think we should discuss how to make real heart teams, because maybe here heart teams are all very good, but I know many places where heart teams are just heart team, a name, something that does not correspond to a real strong discussion, balanced way, and final decision. I think that's the point. Yes, we go back. Francesco, we go to the Francesco room. Francesco, sorry, we keep you on waiting, and maybe we can shortly go to the see the echo. We have to see the echo. Yes. Would you agree, Carla? Maybe you can show us the echo and comment together with. Yes.
Okay, so this is the 0-degree mid-esophageal view. And we can see the main lesion that is a flail of posterior leaflet P2 due to chordal rupture. And if we look at the color, we can see the eccentric jet directed towards the interatrial septum. Then we are able to see better. If we move to intercommissural view, now we can also check all the valve in all the portion from the anterolateral to posteromedial portion. This is the cursor here is in the central portion, and we can look at the main lesion, the flail of posterior leaflet P2 due to chordal rupture. And again, if we look at the color, we can see the main regurgitant jet. This is directed anteriorly. There is also a jet that we can look after that is near the main jet, is medially, but is central, as a central direction. I will show you, but it's not significant in severity. This is the main jet. And if we move towards the medial portion, we can see that there is this mild jet, which is central direction. And if we look at H3P3, we can see that the portion have mild prolapse. I show you the long axis view. This is a long axis view. Again, the main lesion, the posterior leaflet length is okay because measure 14 millimeter. The annulus is not so dilated, is normal because the anteroposterior diameter is 32, the intercommissural diameter is 35, and there are no significant calcification at the level of leaflet, at the level of annulus. This is the 3D view, and again we can look at the flail of the posterior leaflet P2, and if we measure here, again the flail width is okay because measure 11 millimeter. If we look at this view through view, we can see that laterally there is a deep indentation, but it's not responsible for any regurgitation. This is the main regurgitation due to the flail. The mitral valve area measures 4.4 centimeters square.
What is the contraindication to the surgery?
This is the mitral valve area. In this view was 4.1, but also measure in transgastric view was 4.4.
Okay, Carla, so let's go to Francesco. And I got just a question from Professor Di Bartolomeo. And what is the indication, what is the contraindication for surgery? And so probably Francesco can have a surgical result with the transcatheter intervention. Let's see if this will be the final answer. Francesco, I think we are running a little bit late. Just go straight to the procedure, to the transeptal puncture.
Yes. Okay, so I hope you hear me well. This is the transeptal puncture system I have in my hands. This is the dilator, and this way, here. And we use a 032 wire to go. We can show the fluoro now. We go up with the wire, and we reach, hopefully, the superior vena cava. We advance over the wire. The transeptal system is a SL0, is a braided transeptal system. The transeptal catheter is put in the superior vena cava. And now we have to shape the needle. I want to achieve a posterior puncture, so I will, I hope you can see my needle. I put my needle here somewhere. You see the curve. I will increase a bit the curve on the tip to get more posterior and more inferior. And then I will do a little bit of additional curve in the middle to increase the pressure on the septum, to see better the tension. We advance the needle. We release the stylet. Now I will hold the needle with my right hand with the technique that allow me to clock it posteriorly. On fluoro, I want to see a straight line,
yes.
Which means
Yes. Corrado, Alessandro, show the echo and fluoro, please.
Okay,
yes.
Show echo and fluoro together. Yeah, fluoro can be very small and echo can be larger. So now you see the bicaval view. Okay, fluoro, you see we are AP view and it's a straight line. In bicaval, I start seeing the tenting in the muscular portion, the fossa is below. I pull back, keep going back, now I jump into the fossa. I will come back a little bit more and rotate clockwise. And I think I am tenting in the right position. So we switch from bicaval to short axis at the base. I don't see the tenting, but if you look at the fossa, you will find me. Pretty sure. Here it is. We are very posterior, pretty inferior. This is the best position possible. I will now hook it. You can measure the height if you want in 4-chamber view. I just tell you I don't do it anymore in my daily practice because I know that this measurement is somehow misleading because it's nothing to do with the height of operation afterwards. But this is the standard procedure. So you see we are probably, compared to the annulus, relative to the annulus, we are almost 5 centimeters above. We will measure now.
Francesco, while Carla is measuring, can you a little bit elaborate on the last thing you said? So why this is useless?
It's useless because the working height is not only relative to the point of the puncture. The position of the puncture will be one of the constraining elements of the manipulation of the device. But if you puncture posterior inferior, always you gain height as you push the system forward. I showed you very briefly this morning this concept. We are teaching this concept in our transseptal course that clearly defines that if you so 4.5, which is fine. Let's go back to the short axis at the base. So if you puncture posterior inferior, basically you reach a working height which is ideal in all cases, and also you have a very coaxial position. Now this septum is pretty floppy, so we wait a bit. If I push, I can puncture the roof. You see, the roof is in front of me, so I do a little bit of little things, and here it comes. You have to be careful not to damage structures. Okay, now we have done the transseptal, and we give heparin. Facciamo l'eparina. So we let back bleeding. I don't flush too much. I'm always very careful to inject any air at this moment. And I will now show you one little trick that can be very useful, particularly in functional MR, probably not in this patient. Now, this patient is not super simple. You think it's simple, but it's not super simple. I think even for surgery it will not be super simple. If you see in the anatomy, we have some in the anatomy we have a flail, but also there is a cleft just between P1 and P2. So there are some little things that are a little bit disturbing. Okay, the wire goes now in a pulmonary vein because we are outside of the shadow of the heart, and I will advance the sheath into the pulmonary vein for safety. That means this is quello lungo. So this is a super stiff wire. It's a bit different from the one that I use. I use a 1 centimeter long. It's okay. Happens. It's fine. It's okay. Not bad. No one. So we put 2 wires. It's called the buddy wire technique. And over the 2 wires now, we will advance the pigtail to measure the pressure continuously, and we will advance the guiding catheter. So, cominciamo col pigtail prima qua. So first, now you can see on fluoro, there are two wires. One is stiff and one is the regular floppy wire. But as you know, you can measure the pressure continuously, also with the delivery system from the mitral clip, but the measure you can obtain from an independent picture is obviously far superior in terms of reliability. So in cases where you expect potentially a difficult outcome in terms of MR reduction, it's always important to know if there has been any hemodynamic improvement or not, or if you are causing stenosis. Puoi lavare le linee di pressione, per favore? La linea gialla, sì, scusa. Sì, vai. Avanti a lavare e siamo in lettura. So now we have a yellow, we have a LA pressure. Mettiamo la scala gialla a 30. Okay. Now we have to introduce the dilator, the guiding catheter. Guiding catheter is the first catheter that has a steerability.
Can you go to the fluoro more? Put the fluoro on big. Switch it. Put the echo small, fluoro big.
Alessandro vuole vedere più la scopia? Più grande dell'eco?
Okay, now we introduce the guiding catheter. It's always a bit tricky. It's a 24 French. Tieni meglio la guida che stanno troppo dentro. Okay. Questo è il trucco. If you push on the fossa here, it will be easier to advance. You have to keep some watering because you need to activate the hydrophilic coating. Okay, now we are reaching the septum with the dilator, the tip of the dilator, and at this time I have been advancing the dilator to help the introduction to the skin. Now I pull it back, and now slowly I let the system slowly enter. You can see the lines of the tip advancing slowly into the left atrium. And I think we are probably already in. No, we are not. Not yet. 1 second. So we wait. I don't push now. If you push, you may create lesions. Okay, it's coming now. It went by itself. So we had to wait and let the septum accept this instrument. Okay, non tira niente. Okay, now we stabilize the system with the holder, the stabilizer. And we give some curves so we know how much. Andiamo in bicavale, per favore. So I like to use a bicaval view to identify the tip of the delivery system. Okay, in bicaval usually it's easy to see. And I want to have 2 centimeters, manca la vite qua. I want to have 2 centimeters of guiding catheter into the left atrium. Now, it's a very important step because it will simplify the next steps. There is a wire still in the left atrium, so if by mistake I exit the septum, I will be always able to come back because the wire is there. But now that it's stable, I know I can now really retrieve the wire, so we pull the wire. So on floor you can see we pull the wire back. Dilator was already in to identify the tip. The wire is back into the dilator, and now you can pull it out. We are de-airing as we do this maneuver. We minimize the risk of embolism. we flush this very large catheter for a while. Okay. Now we're ready to introduce the second delivery, the second catheter, which is also steerable. So we have 2 degrees of steering, because this is a truly robotic system. The 2 catheters have a key, so they can steer independently on 2 planes. And that is the main advantage of mitral clip as compared to Pascal, in my opinion, at the moment. Still, the precision of this device is far superior. And so in a patient like this, I have no doubts that this is a better solution. And now we will do this maneuver, which is sometimes takes time, particularly for beginners. We are going to do it mostly fluoro-based, which is advancing the 2 catheters in order to have the markers. We have to stop the alarm because we are going beyond. Non c'è bisogno, siamo già pronti. And now that I have this configuration of floor, you see we are almost 90 degrees. We can go on in intercommissural view. Intercommissural view, and we should be already there. So now next step is to obtain the coaxiality. So we wait for a good intercommissural view. Now, what is a good intercommissural view? Is the one where we see 2 papillary muscles, like this one, for instance, is a good one, in my opinion, and ideally having the apex in the middle of the screen. This is a very acceptable one. Now, what we need to achieve now is coaxiality. So, as you see, the clip is, if I move the clip, is moving from medial to lateral. So we have to increase a little bit the medial deflection in order to be more coaxial. Now we are perfectly coaxial. And then we need to have some coaxiality also in the other plane, because we need to move towards the tip of the papillary muscle. And I think now we achieved a pretty good coaxiality. I keep on trying, changing slightly the amount of steering until I'm happy. See, we are coaxial. So number 1 is coaxiality. If you have coaxiality, you move easily. Getting coaxial was done with minimal manipulation because of the posterior and inferior puncture. And so now we are ready to open the clip arms and start
Francesco, before you continue,
yes.
Before you continue, can you explain a little bit better what kind of movement you can do and how you get it? I mean, anterior, posterior, medial, lateral.
Absolutely. Yes. So, as I told before, this is a robotic system. You can use a number of knobs to adjust the angulation, let's say the steering components. Also, you can move around by simple maneuvers. So, if I push the whole system forward, we need to show also the echo.
Francesco, wait 1 second,
Show the echo.
Francesco, wait 1 second. Alessandro, put the echo on, yes. Echo big.
Okay.
Echo big.
Okay. So, no, I think this is perfect. Fluoro, echo, and everything. Put the echo, fluoro, and the maneuvers, like before. Okay. This one, perfect. So, I am pushing now the whole system towards the head, so cranial, and I move this way from medial to lateral. If I pull back, let me just go up, I don't want to get entangled. If I pull back towards the foot of the patient, I go caudal and I go medial. Then I can go anterior by counterclockwise rotations of the guiding catheter. I can go posterior by clockwise rotation of the guiding catheter. My right hand is on the clip, my left hand is on the guiding catheter. This will be all time during the procedure. Obviously, there are many knobs here. They are somehow sometimes confusing. I just want to understand how to use them. So let me close the clip so we see better.
Now, imagine you start the procedure with this situation, where you reach the valve like this with a very, we call it aorta hugger. You are coming from anterior and you are not coaxial. To improve coaxiality, you have to act on this knob, which is pushing the whole system more posterior, and you now get coaxial. I mean, these are very important details. All the rest, which will come afterwards, is really not so important. We need to be super precise here. You see that there is not too much movement medial-lateral, but you can see I'm not moving my hands. And if you look at the clip relative to the flail, in some moments we are on top of the flail, some moments the flail goes almost 1 centimeter away. This is the result of breathing. That's why we will grasp the leaflets with a apnea, with some stop ventilation, but we will do it later. Because first, now that we achieved the coaxiality and the orientation, and the trajectory, it's the time to assess the orientation of the clip. We need to be perpendicular to the line of coaptation. And we need to check the grippers, liscio posteriore.
You have to take the...
And so now we need 3D echo. This is the real situation where 3D echo is fundamental.
You give the presentation. You going?
Okay. Now we will reduce a bit the gain.
Now.
We will clock on this picture. I will move away from the target so we see better.
I think in 10 minutes.
And I pull back and I go on the target. And I think this is a very reasonable clocking. Okay? So according to this clocking, I will hold the clip. And I want to see on fluoro, by craniato. On fluoro, I will align my clip system like this. Perfect. Now you see the clip arms are invisible, are in line with the delivery system. This will be my clocking. So I will keep fluoro during the grasping to keep this clocking all the way. Because the time you cross the leaflets, that will be your clocking. No reason to reclock below the leaflets because I always tell the interventional cardiologist there are some cords below the leaflet, so you can't change the clock once you cross. So we're ready to grasp. I already closed the clip partially. I keep a little bit the clip open because I want to be sure I don't get entangled. So we will stop ventilation now. When
Francesco,
you stop ventilation, the whole system goes always medial. Yeah, please.
What is now? So you have talked about the clocking. What is the influence?
Sorry. We are stopping ventilation. 1 second. We need to move. Okay. So now we enter the leaflets. I will answer to you as soon as possible. Let me do this maneuver. So I'm working very slowly. I just go just below the leaflets, reopen the clip arms, and I'm there. As you see, the diseased lesion is already there, is jumping. I'm doing almost nothing. I position myself nicely in that region. The grippers are down. We close, and you don't see the pressure line, but I can tell you we start from 14. B wave, 13, 14, it's same here, doesn't change too much, so probably we were not so, okay, possiamo iniziare? So this is now the clip position. Let's see what happened in terms of MR reduction. As we were somehow predicting, there will be a little bit of residual from the cleft, but the flail is probably well covered. Sorry, I didn't. So the question was, now we can.
The question was, what is the influence of the indentation? So if we're doing surgery,
Yeah.
you don't want to go into the indentation or cleft or whatever you call it. What is the influence now? Does that have any influence, any impact on your strategy? You go far away to avoid it. You go to that. So what do you do then?
Yes, great question, and very much related to this case. We try to get as far as possible from the indentations. As you can imagine, as you know, because we see indentations, they are areas where there is a limited amount of tissue, and also there are a lot of cords. So anytime you go in the indentation, you have a lot of problems. You can make distortions. So if you are very close to indentation, you might get into trouble. Now here in this particular case, this is why I consider this case not a simple case, just because we are very close to a large indentation. But it looks to me that till now we obtain a good result. You can see the leaflet insertion is very deep. There is no more this eccentric jet component, so we don't see any fluid moving. There is a bit of jet coming lateral from the clip. I think at this moment the strategy, let's say the steps are the following. First of all, we have seen MR reduction. Second, we have seen leaflet insertion. Now we need to check the gradient. The gradient under these conditions is probably 5. Let's see. It's not small, eh? It probably is a pretty. It's 3. 3. We also had the continuous pressure monitoring that is also very important. Another very interesting factor is that AR, aortic regurg, probably is a little bit increased. This is very common in patients with combined lesions because we reduce the left ventricular and the diastolic pressure, and then you get more AR after these procedures. It's very common, and this is to answer Grigioni about the step approach. The last, if you want, view before releasing the clip could be a 3D surgical view. You can do, if you want, a glass view just to make some beautiful pictures. They're always good. I love them. I love the glass view. But glass view could be helpful to identify eventually the flail if it's not being captured by the clip. It looks like we are where we wanted. As you can see, there is a P3 which is not normal, just medial, and that is something that is somehow a little bit disturbing and struggling for me. But on the other hand, I don't see the cleft anymore. Sorry, the cleft. I don't see the flail anymore. And as you can see, we are very close to that damn cleft that is always disturbing. So anyhow, I think we are okay. So now, is the procedure finished? We don't know. Let's see. Now we will release the clip. We will check if we'll check if the clip closure is stable. So we do the so-called final arm angle. The clip is not opening, so the locking system is working. And so we are ready for releasing the clip from the delivery system. There are some maneuvers which are very standardized. You have to remove some of these sutures which are there. And then basically detach. And the clip is detached. It's released, and now is the time to assess MR reduction. Now, we see there is a little bit of a jet coming from that cleft. The jet is completely different compared to baseline, obviously. Completely different. No, sure. Completely different because it's not anymore eccentric, it's central. It is due to that cleft, and for this reason, probably it will be something we need to accept. We can't treat. We don't go into the clefts. We learned this times ago. But I let my imager to assess the residual MR, so you can probably take over.
I think this is a great result, Francesco. Surgical result. Very good for 80 years old man. Thank you very much, Francesco. I don't know if there are quick questions because we're running a little bit late. I think this was a great demonstration of a catheter-based procedure done by a surgeon for a patient that probably many surgeons would treat surgically here. But I think this result was just exceptional, very good. Anatomy wasn't that bad, despite the cleft, so it was favorable anatomy. That's why we presented this patient to Francesco for a catheter-based therapy. So I think we can go to... Thank you very much, Francesco. Big applause for you. Excellent result. Excellent result. Thank you for being with us. Maybe we can make a jump in room number 3, Alessandro, for the final result of the surgery. And at the same time, I would like to call the next moderator to approach the desk here for the next session. Alessandro, please mute the OR. 1 second. We have one question from the floor here. Yes, please, Professor.
Joe,
we're a little bit late. Yes.
Joe, you know how many failure TAVI there were the last year in US? The number of the TAVI failure.
I'm not quite sure what you mean, but there's about a 1.6%, 1.4%.
I have the number. I have seen the last in the last week in China, in the meeting in China, is more of 20,000 cases of TAVI failure. It's a big number. More of 20,000 failure.
You mean that have been reoperated on?
Yeah.
Yeah, that's a different number. Yeah, so there's the number one, the number one highest growth procedure in the STS database is TAVI explant in the United States today. It's the fastest growing surgical procedure in the database. So yes, it's
a very big number. Huh?
Yeah. Now, there's also, interestingly, about a 1.4% rate during TAVI of one of the 3 catastrophes, either a conversion, embolization, or resort to cardiopulmonary bypass. So TAVI is a good procedure. It's not perfect, but yeah, TAVI explant is a very growing procedure.
And another question is to Francesco Grigioni. It's a provocative question. Do you think, what is the incidence of the interest, the company in the result of the study about TAVI, about mitral clip and all the device?
I think companies we have to accept that without companies we don't do research. So I think we have to make regulation in the interaction. There's nothing wrong with that, but this is as it is something we have to accept, because especially in Europe when we don't have the NIH, and for what I see, even the NIH is founding less and less by time as compared to joint interaction with companies. So I think it's part of the game, and we have to sort of deal with to regulate it.
I would like to say, I think Europe needs to do some prospective randomized trials. It's important that the prospective randomized trials are not just from the United States. We need them from Europe. I don't know how they should be funded, maybe through the EU or something, through each national country. But it's important to have prospective randomized trials.
Okay, thank you. Before we close, I just last check to the final result of the surgical case. Alessandro, please go to room number 3 for last echo control And for the last few words of Utz Kappert. Utz, Emmanuel,
Yeah.
we are with you.
Marco, yes. I hope you can hear us. So the procedure is finished. Everything is fine. We are completely off pump. The protamine is inside, and maybe some last words from us. So the greatest experience was to work with your fabulous team. So Marco, you really can be proud of these guys. They are professional, nice guys. It was fun. So thanks to the whole team from us. And now I give the word to Fabio, and he's showing the result. And you will see the valve is okay, the LAA is closed, so everything seems to be nice.
Okay, please, Fabio.
Can you hear me?
Yes, we can hear you. Come on.
Yes, we can hear you. Okay. Normal biventricular function. The prosthesis has a normal function and fine movement of the leaflet. No leaks. From this long axis view, it confirms that the prosthesis function is normal. Mean gradient is 3 millimeters of mercury, and the true view confirms the normal motion of a leaflet. Also, from the ventricle, normal function, normal biventricular ejection function. The result is excellent.
Very good. A big applause for Utz Kappert and the team for a nice case. Thank you very much. Very well done. I think this was a very good session. I don't know what you think about it, but probably we deserve a 50 minutes break before we start with the next one, right? Let's have a coffee. Thank you.
Welcome back again. Please have a seat. My name is Michele De Bonis from Milano. We start this session on a kind of surgery which is, I hope, not going to disappear, because now it's much more rare than in the past, which is mitral valve surgery for secondary mitral regurgitation. I don't have to say many words about my co-chairman, Evaldas Girdauskas, Marco Dosani, Antonio Pizzis, and Marco Solinas. All of you know very well them. And since we are running very late, I will start with the first presentation, and it's a great pleasure for me to invite myself, Michele De Bonis, to give the first talk, which is surgical repair versus replacement, ongoing thoughts. And I ask him to stick and stay on time.
Yeah. Thank you, Michele. Thank you for being with us. It's a real pleasure to have you here. So we make that every speaker will present himself from now on, okay?
Okay, so surgical repair versus replacement. Marco gave me these ongoing thoughts. This is my disclosure slide. And I call this the I'm letting question, because I don't know how many years we have been asking ourselves this question: to repair or to replace in secondary mitral regurgitation? That is the question, maybe. And the only randomized trial which actually tried to answer this question is the CTSNet randomized trial on severe ischemic mitral regurgitation, where patients, as you know, were randomized to undersized annuloplasty versus chorda-sparing mitral valve replacement. You all know these results. Reverse remodeling, which was the primary endpoint at 1 year, was similar between the two groups, but unfortunately in the repair group, which was undersized ring, the rate of recurrent mitral regurgitation was very high, much higher than, of course, replacement. Something which people do not say very much is that most of those failures, let's say, they were residual mitral regurgitation, because 30% of these patients had already moderate or severe MR at 30 days after surgery. This is important. Probably the ring was not enough for that type of situation. And indeed, the only criteria for inclusion was the severity of MR, and in the inclusion criteria there were not predictors of undersized ring failure or something like that. According to the result of this trial in 2017 in the American guidelines, there was this new recommendation, 2A. It is reasonable to choose chord-sparing replacement over downsized annuloplasty repair in patients with severe symptomatic ischemic mitral regurgitation. Now, it's interesting to note that this 2A recommendation has been already downgraded in the last guidelines, American guidelines, to 2B, but nevertheless, it is important we ask ourselves what has been the impact of this trial on the surgical practice and also of this recommendation. And if we look at this paper published by the Michigan Society of Thoracic and Cardiovascular Surgery Quality Collaborative, it's interesting to note that if you look at patients with severe secondary MR, there was no difference, significant difference, P 0.38 in terms of the rate of repair. From 74% to 67%, no difference. In terms of replacement, no difference, from 11% to 13%. So there has not been a huge impact of the results of this trial and of the related guidelines. What has been significantly decreasing has been the rate of surgery for moderate secondary mitral regurgitation, where you see still most of the patients have repair, 93%, but the overall number has decreased from 17% to 7.5%. And this is because the 3 randomized trial on moderate mitral regurgitation did not really show an important benefit of this type of surgery in this context. So why in severe secondary MR the replacing approach has not been widely adopted? The trial says that, replacement is associated to less recurrence, so why we have not been doing this all over the world? Well, because if you put together all the data available, and these are the 6 meta-analyses published so far before and after the CTSNet randomized trial, what happens is that although repair is associated with a higher rate of recurrent mitral regurgitation, if you look at hospital mortality, replacement has never been able to prove that results are better. Hospital mortality has been always lower in the repair group. Even in the CTSNet randomized trial, although this was not powered for mortality, the mortality was 1.6% for repair and 4% for replacement. In addition, short-term mortality and late mortality have always been higher with replacement as compared to repair. Even the latest data, this is the Polish National Registry, have confirmed in over 7,600 patients, overall and also propensity matched, those are the 2 different drawings and graphs about that repair is associated at long-term follow-up with a better survival as compared to replacement. In all subgroups considered, and you can see them here. So the authors concluded that according to their data, repair remains a primary method to treat secondary mitral regurgitation, and the results by no means absolve the surgeon from effort to make the mitral repair durable. That is the key. Try to make repair durable, because if repair is durable, you see the difference in survival. No recurrence, MR recurrence. Durability does have an impact on survival. And durability is related to reverse remodeling. Again, CTSNet trial, the greatest reverse remodeling was observed in patients with durable repair. You see that overall there was no difference between repair and replacement in reverse remodeling, but if you look at the repair subgroups, those who had failure of the repair did not show reduction of end-systolic volume index. In the patients who had repair without recurrent MR, there was a 30% reduction, which is much higher than the 8% reduction observed in replacement. And this is important again. So the question, the amletic question, since there is a role for repair, certainly, besides replacement, is not to repair or to replace, but when to repair and when to replace. In my view, there are certainly patients for whom a durable repair is likely and replacement is not necessary. And those patients are the one showing here, limited tethering, prevalent annular dilatation, a remodeling which is not too extreme, ejection fraction reasonable, around 40%, concomitant myocardial revascularization, AF ablation, which can potentiate reverse remodeling. In those patients, I think repair does play a role. better if it is done by surgeons who have expertise in valvular subvalvular procedures. Because we know from Leiden that if you accurately select your patients, even the ring alone can have durable results. If your patients are with a ventricle which is not too much advanced, ejection fraction which is not too low, you do it properly, then in Leiden experience up to 10 years, the results were recurrent MR moderate or greater 27%, which is actually quite good. But although you can get some good results with the ring alone in selected patients, we have clear evidence now that if you are able to add valvular subvalvular procedures, the results are much better. And this was clear to us many years ago, because this paper you see here, Michele De Bonis Circulation 2005, dates back 20 years, well before the COAPT trial. In that paper we showed at that time that if we were adding the edge-to-edge to the ring, results were better. Interestingly, in 2024, which means a few weeks ago, from University of Ottawa, you see that the authors compared in secondary mitral regurgitation, ischemic MR, undersized annuloplasty, edge-to-edge plus band, mitral valve replacement, in patients according to the surgeon preference, in patients who were comparable at baseline. Again, not too much advanced, ejection fraction around 40%, and diastolic diameter 59, and systolic diameter 48. So timing. What happened? Moderate or greater MR was higher with the ring alone, much better with the edge-to-edge and, of course, replacement. Heart failure hospitalization higher with ring alone and replacement, much better with edge-to-edge plus band. Survival, the best with the edge-to-edge plus band, followed by replacement, followed by isolated ring. Multivariate analysis of predictor of mortality, highest mortality with the replacement and the ring. So in my mind, if you select well the patient, moderate is not, tethering is not, is limited. Moderate LV remodeling and dysfunction, repair, in my view, does have an important role. The problem is when tethering is severe, remodeling is very advanced. There are surgeons proposing here very aggressive repair approaches like mitral valve translocation, very good surgeon, but complex technique, long cross-clamp time. You have to detach all the valve, use a large patch of pericardium to attach it to the annulus, and then to reattach the leaflet to the pericardium and translocate the valve down into the ventricle. You can do that, it works, but I think the results are not available at the moment, even a midterm. Long procedure. In my mind, at the moment, I think that when situation is more advanced, I do go for a chordal sparing replacement for sure. Also because, unfortunately, when the situation is advanced, even a durable repair does not always lead to favorable clinical outcome. This is my last paper. Look, durable mitral valve repair for ischemic mitral regurgitation. So all those patients, including this study, have a durable repair, no failure. Survival at 5 years, 50%. Why? Because they had an ejection fraction which was 30%, advanced remodeling, and those in blue, you see here, were those who died or who had the worst outcome, are the patients with more advanced renal failure, higher congestion, higher level of BNP. So timing as important, or probably even more important than how much you are going to make the repair durable. So in conclusion, repair and replacement play both a role in the treatment of severe secondary mitral regurgitation, which is usually performed now only in patients undergoing concomitant myocardial revascularization, at least mainly. The choice depends on the stage of the disease, the alteration of the valve, the likelihood of ongoing or reverse remodeling. Expertise in other valvular subvalvular procedure is essential nowadays to achieve a more durable repair in selected patients. I think we should have a low threshold for replacement if you do not have enough experience with this procedure, or if the anatomy is unlikely to be associated with a good result, and surgical timing remains crucial. Thank you very much for your attention.
Very, very meaningful presentation as always from Michele De Bonis. This title was for you from the very first day, and thank you for being with us. Any questions from the floor?
Maybe I can start, Marco. First question, Michele. I think, in all these trials, regardless of it is surgical or catheter-based approaches, there's always a question, where is the limit of cut-off value to address mitral valve in the setting of ventricular disease? And this is obviously has a major impact on the outcomes. Independently, how do you address them, surgically or by catheter-based approaches? So based on your experience, what do you think, or what do you say, what are, for you, the parameters you would suggest the surgery or go for alternative treatment like LVAD therapy or only conservative treatment?
Yeah, of course, I do not have a value. I think that what we learned, according to all the data we have, both surgically and transcatheter, is that if you want to have an impact on prognosis, you have to act, you know, those who enrolled patients for the COAPT trial, they did the proper job. And it was difficult because to select those patients, that excluded many. But eventually, they were able to identify the patients for whom a prognostic benefit, which has been proven, was possible. Severe MR, small ventricle. That is the key. When you go beyond this, then you can act on symptoms. As you know, we do mitral clip in patients more advanced, where it's unlikely this is going to make them surviving longer, probably better, but not longer. And at that point, whether you are in the, let's say, mitral FR population, then the question between LVAD alternative is related to the general condition of the patient. And most of those patients actually are not real, you know, they are old patients. They have a lot of comorbidities for whom often what you consider a symptomatic therapy can be justified. But of course, if you're dealing with a young patient for whom an alternative, heart transplantation, LVAD and so on, is possible, I would absolutely go for that, because we have, at that stage, you have to impact on prognosis and not on symptoms. Of course, I don't think we will ever find you know, a table telling us the numbers, because that's not possible.
Michele, first of all, great presentation as usual, but already we are, let's say, used to see your presentation, just astonishing. But apart from that, I want to challenge you a little bit more.
I don't hear you, sorry, Marco.
I want to challenge you.
Challenge, yes. I mean, it's very easy to challenge me.
Yeah.
I try to fight, as you know. But
because you are so smart that I think that you can give us an answer. In the decision pathway, do you think that there is a role for something like MRI, some pre-operative, let's say, imaging, but, you know, some assessment evaluation that can tell us as surgeon, probably we are too far to treat this patient, or we have possibilities, apart from replacement or repair, whatever?
That's a fantastic question. But the answer is certainly yes. And paradoxically, I'll give you an example which is related to tricuspid. They are, you know, they are sisters. So they, you know, and the right ventricle is even worse, as you teach me, as compared to the right one. It was very interesting. In my institution, they are submitting a paper where, as you know, for the right ventricular function and tricuspid surgery is a big problem to decide when you should stop or not. And we have the TEER score at the moment, you know, which is somehow helping. And they've done a study very interesting to me where they modified the TEER score, replacing the classical cutoff used for right ventricular function, TAPSE, STDI, which is used in the TEER score as cutoff, with the strain, okay? And what they did, they reassessed all the patients who have been treated with tricuspid valve surgery according to the TEER score, replacing the score for right ventricular dysfunction according to the strain rather than TAPSE STDI. And what they shown, they submitted the paper to European Journal, I hope it will be accepted, is that the predictability of the outcome is greatly improved by this. Because 50% of the patients who have normal TAPSE, normal STDI, they have either a global or free wall longitudinal strain which is below the cutoff of normality. So they are normal according to normal parameters, and they are right ventricular dysfunction according to a new parameter. So that's for sure the way to go. We were using, with Giovanni Lacana 20 years ago, ecodobutamine to see if there was contractile reserve to put a ring in those patients. That helped us to say we can try the operation or we don't. And I'm sure that MRI, strain, those kind of measurements in the future, which are degree of fibrosis, extremely important, are going to help us much more in the stratification of the patients. That's absolutely the way to go, moving from the valve disease to the effect on the myocardium. That's the key.
Yeah, I completely agree. Thank you. So if we have any comment, it's my pleasure to introduce the next speaker, Giacomo Bianchi, that is a friend and a colleague of mine, a cornerstone of our endoscopic program in Massa, that is going to make a presentation, a lecture about how to replace.
Good morning, Chairman, moderators, colleagues. Thank you for having me. I will speak about more technically and how to replace the mitral valve for secondary, for functional mitral regurgitation. Why? Because there is a significant proportion of patients, as we know from literature, and we have an update, a fantastic update from Professor De Bonis, about how only undersizing ring annuloplasty can fail, not in a very long time, but even in short time, and how this patient can experience a recurrence of various grades of MR after this procedure. Not only, but according to the anatomy and the functional part of the ventricular wall that is not moving, like in eccentric remodeling, if you do an undersizing annuloplasty, you will end up not only in residual MR or recurrence of MR, but also in functional stenosis. So undersizing annuloplasty must be done in very selected patient, and also must be considered adjunctive procedure that will be discussed later on. And also what we are doing in this patient, the publication showed that there is no significant difference in terms of mortality or major cardiovascular event, even if this patient pays a little toll in the first period, being the replacement associated with a higher mortality or cardiovascular events, but not power for mortality, as said before. So we are doing that principally for symptoms. And I found this algorithm proposed in 2019 quite interesting, but when a patient are CABG needed and severe MR, CABG plus chordal sparing MVR with, if they have a left ventricular ejection fraction more than 30%, is a reasonable option. Or below that certain point, if there is an option for revascularization and evidence of myocardial viability. But if there is no need for CABG and the MR is severe, cutoff or left ventricular ejection fraction must be considered. If the operative risk is low and the LVAF is over 30%, chordal sparing again, mitral valve replacement is an option. If below, must be considered other options like heart transplantation, LV assist devices, or percutaneous intervention. And this is the way, speaking more technically and more on focus on my presentation, technically how the mitral valve is replaced. This is a picture from many years ago about how to do it in full sternotomy, and how to preserve or not the whole or partial subvalvular apparatus. Recently, moving from full sternotomy to less invasive approach towards the endoscopic approach, was proposed a roadmap on how to pass stitches considering the mitral valve ring. As you can see, the author proposed, starting from the posteromedial commissure, going counterclockwise to the aortomitral curtain, then proceed from the anterolateral commissure below to A1, P1, and then finishing passing the sutures from the posteromedial commissure in a clockwise fashion towards P1. And I will show you now some videos. I didn't find in our library a good example of functional MR, so I will show this kind of interesting video of another patient, but the focus is on how to pass stitches and which is our way. Of course, there are 1,000 ways to skin a cat. This is a partial maintenance of the subvalvular apparatus, mainly posterior. What usually I start to do is going from the anterolateral commissure and in forehand technique, exposing the anterior side, leaving some kind of tissue just not to distort the aortomitral curtain, and progressively you can see how it's quite easy to pass these stitches, and according to the angle that you are facing, you can do it forehand, backhand, and it's really something that you need to acquire step by step as you pass stitches and go on by. Usually is in most of the cases, and this is how I feel it is to do it, is proceeding clockwise from the anterolateral to the all around the clock. And in this case, and in my institution mainly, we used this atrial side pledgeted suture everting. But in other situations could be equally, let's say, effective to pass it from the ventricular side, especially when you have small annuli and you want to accommodate a bigger size of valve. Also, I can skip to the next one. That is a quite special case, and I want to show here in the right angle. This is a transplanted heart that acquired a pathology. So this is the final steps. As I told you, this is backhand. It's possible to inspect all the aspects, and this is a biological valve replacement. The next one is a very tricky situation, not a functional one, but this patient also had a mixed pathology. She was a atrioventricular septal defect, then that developed annular dilation, low ventricular ejection fraction, and I'll go for a replacement in this case. And I try to spare, so actually what I did, I spare all the tissue. And this is an anatomical reason also, because the gooseneck outflow tract, I didn't want to impinge it, and I try to avoid any distortion or impingement on the leaflet. As you can see here, I proceed in a different way, but usually in endoscopic is the way that you feel more at ease and not to be entangled by your stitches itself. So I can skip a little. Basically, it's all the same. Here was completely spare the subvalvular apparatus. In literature, there are many papers that try to assess the difference between subtotal or total sparing. They found no difference whatsoever in terms of mortality after this kind of sparing. And in the very end, I place in this case a mechanical valve, so because the patient was really young. And to sum up, this is the way we can propose, but usually you must be at ease. Forehand from the anterolateral commissure towards the posteromedial, and then backhand running clockwise, and in the last part can be backhand or reverse forehand. Thank you for your attention.
Thank you, Giacomo. Nice presentation. What I in functional MR, I try always to spare both leaflets, the posterior and the anterior. What I do normally is to split vertically or horizontally sometimes also the anterior leaflet and fold the leaflet down up to the anterior annulus and just a comment. But when we go to replacement, choice of valve, because these patients very often are sick, a little bit old, with reduced impaired left ventricle function, so their expectancy of life is a little bit shorter. So do you have any, different threshold for age limits with the mechanical versus biological? How do you work with that?
Well, in this kind of, if I have to say about the literature, they found that actually no differences in events, maybe mostly, let's say, because the short lifespan of this patient. So basically, the final goal is to reduce or make zero the residual MR. So this is basically what impact. In terms of events like bleeding, there is some conflicting results between literature. Somebody can say that bleeding can occur more often with a mechanical valve replacement, but this is not, maybe from historical series, most recent series found no difference at all.
This is the literature.
Yeah, and in our
your hospital, do you
in our
stick
hospital,
to literature, or
we just try to stick to the age of the patient and the guidelines, and also patient preference.
Yeah, maybe we favor a little bit more a biological valve when we operating on these patients, because Professor Di Bartolomeo, yes.
In case of one part of the annulus have a big calcification, what is your technique? To remove the calcium or no?
Usually, if it is feasible, to work around the calcium. Yeah. Just like passing the stitches around it. And if you have a very big calcification, then we can also try to open it, but you know that there are some adjunctive techniques, like after very big decalcification of the posterior, you can reinforce the posterior side, flipping the anterior leaflet towards the posterior and make it like a patch, and then pass the stitches.
This is a very dangerous problem, because many times there is the rupture of the left ventricle. I used to leave inside the calcium and to use the onyx valve, because with the onyx valve it's possible to not remove the calcium, not to remove the leaflet, and it's possible to conserve also the chorda.
Sure.
Beautiful. Yes, if we were making with Evalda a little comment about this, according to the question made by Professor Di Bartolomeo. We have been both used in, myself in very few cases, 3 or 4. The splitting on the, when you have calcium, okay? I never remove calcium, first of all. I don't dare to do that, so I cut the anterior leaflet, and as it is, simply move it backward on the posterior one and use it as a pledge.
As a pledge.
You stitch through it, and you become, the risk of rupture of posterior wall becomes much less, because the tension is distributed on that. It's very simple. It's extremely simple. So I find really, I would like to recommend this. I knew about that. I didn't use in the past. I've been using 3 or 4 times in the last year or so. And it's really, you know, I would advise that. Okay, any other question from the floor? No? If not, thank you very much, Giacomo. And we move on, and we ask now Evaldas Girdauskas, who is one of the really experts, I would say, in this associated procedure, particularly in dealing with the papillary muscle, how to repair these secondary mitral regurgitation patients. Thank you, Evaldas.
So good afternoon, everyone. And first of all, I'd like to thank Marco Deusano for putting this excellent meeting together. It's really a pleasure to be here, Marco. And my talk will be about the technical aspects of mitral valve repair in the setting of secondary mitral valve regurgitation. So what we do know, everybody of us know this, but when we deal with these patients with ventricular secondary mitral regurgitation, we were dealing always with the issue of the tethering. So everybody knows it's a ventricular problem. And the main pathophysiological mechanism leading to the mitral regurgitation in this setting is a downward and apical and lateral movement of the papillary muscles, increase of the distance between papillary muscle tips and the mitral valve annular plane, which leads to leaflet tethering. So this is the main pathophysiological background, which obviously has an impact, should have impact on our repair strategy. And this is the reason why you cannot treat these patients with an isolated annuloplasty, because the tethering issue is not addressed. Even the smallest ring you take, you use, will never address the tethering issue. And that's why, if you want to repair these valves appropriately, it's my personal opinion, this has been shown by different studies until now, that you have to address this pathophysiological mechanism. You have to reduce the distance between the tips of the papillary muscles and the mitral valve annular plane. And one of the most appropriate and reproducible ways to do that has been shown based on the data of meta-analysis is repositioning, relocation by different surgical maneuvers of the papillary muscles, which basically leads to the coaptation line moving up to the left atrium and relieving the tethering issue due to the reduced distance between papillary muscle tips and the mitral valve annular plane. So the technique we have been using since 2016, over almost 300 patients until now, is the placement of a separate PTFE sutures in both papillary muscle trunks, anchoring them as a U-type suture, pleasure support in both trunks of the papillary muscles, advancing in from the ventricular part into the atrial behind the posterior mitral leaflet. And then, when an annuloplasty ring is placed inside, both of these sutures are advanced behind the posterior aspect of an annuloplasty ring. The left ventricle is pressurized, filling it with a saline solution, and then the repositioning maneuver is performed as demonstrated in this video, pulling it very slowly, step by step, adjusting the traction on both these anchoring sutures and tying in on the posterior aspect of an annuloplasty ring. This procedure has been demonstrated to be reproducible even in a prospective multicenter study, which has been performed in Germany in 6 participating centers. And the recurrence rate is completely different as compared to this, which was reported by in ACA CTSNet score. We had in 100 patients included in this registry, we had only 10% recurrence rate of MR grade 2 and higher after 2 years. Nonetheless, after all this time doing this procedure, I have to admit there are several subjectivity aspects which obviously are an issue, especially how much do you pull on these papillary muscles, how much you pressurize the ventricle is something is a little bit subjective, and the question has been, is there any possibility, based on the modern imaging strategies, to make this procedure more simple and more reproducible? First of all, what we did, we measured, based on MRI, the distance between mitral valve annular plane and the papillary muscle tips on those patients who already underwent this papillary muscle repositioning procedures. And you can see on the slide the distance has been reduced by 5 millimeters on average, and the median distance was 25 after performing this procedure, 1 year after that. The next issue is, it has been demonstrated very nicely in a live case by Francesco Maisano. We can use real-time TOE, intraoperative TOE, using the intracommissural view, which can depict and visualize very nicely the papillary muscles, and we can do, based on these, online real-time measurements between papillary muscle tips and the mitral valve annulus plane. And the idea has been, based on these measurements, we can perform real-time on the echocardiography. Can we use a pre-measured PTFE loops, as they are used in degenerative mitral valve disease, to simplify the papillary muscle repositioning procedure by selecting the loop size, which is 1 to 2 sizes smaller as compared to the measured distance, depending on the severity of a tethering. And I will demonstrate you one patient, which this is the first patient we did this procedure, as a 60-year-old female. Typical story, it was previous myocardial infarction, rescue PCI, already at the discharge after initial procedure, a severe secondary mitral regurgitation, which does not change much after 3 months of a goal-directed medical therapy, and the decision of the heart team was after that to go for minimal invasive mitral valve repair. So this is a video of intraoperative TEE. The ventricle is not too bad. It's a moderate phenotype of a heart failure, I would say. Here's an intercommissural view. Here's a measurement of the distance between papillary muscle tips and the annular plane, which was 28. And based on rather modest tethering issue, we decided to go for 26 millimeter loops in this case. So initial valve analysis demonstrating structurally normal mitral valve and typical tethering at the level of a posterior medial commissure and P3 segment. True sizing of a mitral valve annulus, as always done in these valvular procedures. No downsizing, so selecting 28 millimeter ring for after that. And then we anchor the pre-measured PTFE Gore-Tex loops as is used in degenerative mitral valve disease. I'm coming from a Leipzig school, so I was used to use this over the years for degenerative mitral valve patients, as many of us. Then fixing these loops on the posterior medial papillary muscles in the first step. And you will see the same will be done on the anterolateral papillary muscle. Selecting the good tissue at the tip of the papillary muscle, with which have a little bit fibrosis there, as you know. Tying with the second PTFE loops. So when you take all the loops in this additional suture, and the same as you would do in the original procedure of papillary muscle repositioning, you hold just behind the posterior mitral leaflet, advancing the suture from the ventricular surface to the atrial for the anterolateral papillary muscle between P1 and P2. And for posterior medial papillary muscle between P2 and P3. Okay, when the normal 28 millimeter nulloplasty ring is implanted, based on the size of anterior leaflet, we advance with both sutures through the posterior aspect of an nulloplasty ring. And when the loops are fixed on the posterior aspect of a nulloplasty ring by doing that, so we know that we have 26 millimeter distance between the mitral valve annular plane and the tips of the papillary muscle. And therefore, there is no need to perform a water test, which was required in the original procedure. And you just tie both of these sutures on the nulloplasty ring. So we just fill the ventricle to look how the valve is looking. Pressurize a little bit more if you want. And this is the intraoperative echocardiography showing competent mitral valve. We did an intraoperative pre-discharge echocardiography in this patient, demonstrating a good result after the surgery. She did very well. She was extubated in the OR in our ERAS program and went at home on the 4th postoperative day. The result is stable until now, and it's obviously this technique is a work in progress. We did 10 cases this year using this technique, and the findings are very promising until now, and obviously we are trying to evaluate this from a scientific point of view, putting a prospective study on that. Thank you very much.
Ciao, Michele. Michele is trying to catch his train. So, Evalda's great presentation as always. This is a very difficult topic. We have done so many discussions over the years about this topic, and I'm very, it is great pleasure for me to see you, doing this pre-measured loops job. So, congratulations. How many cases of pre-measured have you done so far?
10 cases.
10 cases. And pleased with the outcomes?
Until now, they are very stable. Obviously, we have only a couple of months follow-up now, until now. So the question is, will the result be the same as the original technique? And I would suppose that it will be, because there's only more reproducibility in the technique, but basically nothing's changed by that.
So you always use this sort of length, 24, 26, let's say, you have settled for this number. So a few technical things now.
Okay.
So first of all, why you used 4 instead of 2, let's say?
Oh, I think you can use 2 too. I think it's not a really major issue. You can fix even with 2 points, I think, if you want. But I don't think it makes major difference, because it's just about the length between the tips of the papillary muscle and the mitral valve annular plane. And as you told already, the typical case is 28 or 30 millimeter ring plus 24 millimeter loops, and it functions in 80% of cases in my experience until now.
So I think this is very important, because this is a technique that depends on art. And what is the art here? The art is how much you're going to tie this suture. I mean, this was the original technique of yours. Now, this is very difficult to teach, almost impossible to teach, because in order to get there and know how much you're going to tie and become a Valdes, you have to do 300 cases. But this is not good enough, because after 2 or 3 failures, then the interventional cardiologist will do, a transcatheter approach, and they're not going to refer a patient back to you again. So if we want to remove art from surgery, and I think this is the aim of this workshop and any workshop, it has to be surgery for idiots, surgery for fools. It has to be measured on TOE. So we have to say that this patient needs 24. If we say to people that this patient needs 24, anyone can do it. But if we say that you have to be a Valdes to tie the suture, then it is art. So I think first point, that this is the only way forward. The only way forward for surgery is to take art out of the equation. Now, a few technical things that I think secondary points is consider that every time that you use more loops than needed, you create a thicker area of PTFE, EPTFE, not PTFE, and this is another word of caution. EPTFE, as you know, is something that it is very flexible. You can pull it, and it is very elastic, so it will calcify eventually. So the more loops you have, the thicker the EPTFE will become, the more the risk that you are going to have trouble in the long-term outcome. And my third point is, instead of EPTFE, use PTFE, because it is not elastic, it doesn't elongate, it doesn't have air pockets, so you have better chance after 10 years or 15 years for a durable repair. I think this is maybe something to tell us in the next meeting.
It might be, thank you, Antonio. I think it's excellent. Your points are excellent. And obviously you have to look and think at the results. What I personally love at EPTFE is this 10% elasticity, flexibility, because you always have to think what is the risk of a rupture of these sutures, you know. And I personally believe after using a couple of years only PTFE materials, I saw a couple of ruptures of a chordae. Using a PTFE material, especially if you take a single ones. And I personally love the EPTFE material. Regarding the long-term issues, you have to look at this, I think.
One short question from the floor.
Yeah, this is Yang Choi from Bad Nauheim in Germany. I have a brief question regarding the length of the loops. They're surprisingly quite long. When you're, for example, using the Memo 4D ring with the relooping system, you're almost putting the resuspension of the neocord to the annular plane. And this is usually for the posterior around 16 to 18 millimeters. You're a lot longer, although you're fixing them to the same plane. Can you explain this?
Yes, I think it's an excellent question. I think it's about the question degenerative versus secondary mitral valve regurg. I think in degenerative mitral valve disease, you have a normal ventricle geometry and the distance between papillary muscle tips and the annular plane is much shorter. And this is probably the explanation why. If you do it in remodeled ventricles and measure the distance, and we did it in almost 300 cases now, we measure just consecutively the distances between papillary muscle tips and the mitral valve annular plane. As the ventricle becomes larger, the papillary muscle moves down, and the distance becomes something between 28 to 30 millimeters. So putting them 5 millimeter up at the level of 24, 25 seems to be a good option in these large remodeled ventricles. This is a difference to degenerative mitral valve disease.
I think we have to move on, but just as a word of caution, our average length of loops in Thessaloniki is 24. It is not 16 to 18. But we have to move on. This is a long discussion.
I think the last presentation has been cancelled, Leonard had to fly away, let's say. So I don't think we have time for a coffee break. We had just half an hour ago, maybe. So we can move to the next session, hot topics. And I'd like to invite the next moderators. I'm just... Yes. I'm keeping you on. We can bug you. Yes. And the next moderators, please, can approach the stage. Dr. Babliak and Kempfert, your Kempfert. I don't know, one second. York. And myself, yes. And there is a surgeon who's replacing Dr. Prashant from India. I'm sorry, I got the wrong program, so I don't have it on my program. No. Dr. Prashant from India. We have a speaker that is replacing him for his presentation. He can join us here if you want. No. Okay. So, Antonis, as you're there, you can start with your presentation probably, okay?
May I have some help connecting my computer? So, the presentation about myectomies, Marco, is that correct?
Sorry?
The myectomy presentation? Yes. Okay. So I think what I'm going to say in the next few minutes is about our experience with myectomies in a minimal invasive and especially in endoscopic world. So myectomies is a real issue in the surgical community because we don't have enough centers to perform myectomies. So certainly we have to train more surgeons and more centers, and we have to develop expert centers. So let me see, where is my presentation? But it's going to be a technical presentation, and obviously what we will try to do is it connected? Why nothing seems to happen here? Okay, excellent. So this is the list of my disclosure. You are all invited to Thessaloniki. We have been through all these things, but let's go to myectomy. Septal myectomy versus septal ablation. Certainly, we have to compete against the interventional cardiologists performing septal ablation. But the evidence that we have so far, not from randomized trials, obviously, but from very good studies that they are propensity matched, like this study, is that septal myectomy remains the gold standard of treatment. So we have to really try to improve the numbers and the numbers of surgeries, and that means the number of surgeons performing these operations. This is our experience in Thessaloniki in recent times. So we do, every 2 or 3 months, we do a myectomy. And this is our approaches. So we have 2 approaches. We have transaortic, which is, we try to copy, obviously, the Morrow procedure, the extended Morrow procedure, and we have also a transmitral approach. And we can discuss pros and cons of the 2 approaches. So this is the transaortic approach. So it is more or less a pretty standard aortotomy, as we do in a total endoscopic aortic valve replacement. You have all seen many, many cases of endoscopic valve replacement. So it is an aortotomy that we do rather distally, more or less at the fat body of the aorta. You can see the case, the echo. There is no question that there was gradient, significant gradient. There is basal thickening of the intraventricular septum, and this is more or less our usual setup. So we have done the aortotomy. Here, unfortunately, here you should see the image before I put the nitinol protector device. Obviously, as soon as you open, you are going to see the aortic valve leaflets. But then you are going to, in order to protect the leaflets, the most important part of this procedure is to protect, obviously, the aortic valve, is to use this self-expanded nitinol device, which is quite a great device. So I think we need it even for open surgeries. And as soon as you have sprayed out the aortic valve leaflets, the next thing you're going to see is obviously the intraventricular septum, the anterior mitral leaflet, and this area of fibrosis. So the aim of the operation is obviously to do an extended myectomy from here, from the one fibrous trigon, the posteromedial, or the right fibrous trigon, all the way to the left fibrous trigon over there. So in order to have done a good job, you have to start from the one fibrous trigon, paying some special attention, obviously, to the bundle of His. LBBB is very common after myectomy, but complete heart block is extremely uncommon. So in order to do that, first we place a few sutures so we can have some pulling power. And the most important technical thing of this operation is that you have to pull hard and try to cut everything in one go. You shouldn't you shouldn't do multiple cuts, because with multiple cuts the tissue becomes really messy, becomes like a dog's food. You have to try to do it in one go. And obviously, cutting is usually less than more, so you should really take a very deep cut. In this sort of procedure, because quite often we have visitors in Thessaloniki, if I judge the completeness of the cut by the reaction of the guy who is next to me. If the guy starts, breathing heavily and sweating, then I know I have done a good job. If the guy remains calm, then I know that the job is not good. So I have to try harder. And the aim of the operation is to remove enough tissue the amount of tissue, we actually weigh the amount of tissue, and the amount of tissue that we usually measure is something like 10 grams. I'm not happy if I take 2 or 3 grams of tissue. I'm happy if I have more than 8 grams. Been very happy if I have double figures. So again, this is another case of transaortic. You see the aortic valve leaflets. We are getting ready to put the nitinol frame to protect the leaflets. So don't be afraid to use the nitinol frame. It's very gentle to the leaflets. As soon as you remove it, it is, you know, business as usual. There is nothing, no marks or anything on the aortic valve leaflets. I think this is the most important part of the operation. As soon as you protect the leaflets, then obviously you have a protector, that the protector also acts like a shield against, you know, whatever you do. But you have to remember, you have to pull hard on these sutures. You have really to expose the basal part of the septum. And now the next question everyone is asking is, how much do you cut? How do you know? Well, you know, this is, again, as we said in the previous session, we have to be able to measure it. As long as we are not able to measure and give a clear answer in advance, then obviously you need to have a lot of experience and training. Yes. So I'll get this. You've got the idea of the transaortic. Suppose it is quite straightforward because it is exactly the same operation that we are doing in open approaches. And then obviously we have to remove the nitinol frame, which is, as I said, something that has absolutely no effect on the aortic valve leaflets. So I'll go to transmitral and present a case of transmitral, and then we can discuss why this and why the other one. So this is again a case of basal hypertrophy with some, there's no question about that. Transmitral, we have to go through the anterior mitral leaflet. So we have to violate the mitral apparatus. And this is something that I'm not very happy doing unless there is some issue with the mitral valve. So because we don't know the long-term effect of violating the anterior mitral valve leaflet is going to be. So if we go through to the transmitral, obviously again it is a standard approach like we do with any mitral, and obviously we're going to detach the anterior mitral leaflet all the way down to the commissures. So this is the views that we get. Obviously, it is slightly different than the normal mitral because there is a lot of hypertrophy. So everything seems to be very, very, crampy, let's say. So when you detach the anterior mitral leaflet, we try to leave a few millimeters of tissue, because obviously we have to reattach somehow, and we have to have good tissue to suture. Then I'm going to detach again the trigons. The trigons are very, very important, so don't stop high. You have to go low. And sometimes I detach also the commissure. And then again, I try to take in one go. Going in one go is the most important thing of this procedure. This is an old video. Today I would have put a stay suture here, and I would have passed it behind the nitinol, so I would have traction. You can see very well all the way up to the aortic leaflets. You can see actually the aortic leaflets, and don't forget that you can get your camera further in and twist it, or even you can use a dental mirror if you want to. But you have excellent imaging, and you can take your time, obviously. It has to be a big chunk of myocardium. And remember to weigh this amount of myocardium. Should be 10 grams to be happy. I know that most of the surgeons wouldn't agree with the weighting of myocardium, because different patients have different sort of hypertrophies, but we have to take a substantial amount out. Now, what are we going to do about this hole that we have created in the anterior leaflet? In the old days, we used to use bovine pericardium. Now we have switched to EPTFE. So EPTFE, unfortunately, 0.1 of a millimeter is not good material because it is very fragile. We make valves out of 0.1 for the pulmonary position, but not for the mitral. It is not easy to suture with the endoscopic instruments 0.1. So we have moved to 0.4 of millimeters of PTFE, this membrane, and we size it according to the sizes of the mitral valve. So let's say that we are going to implant, if we were to implant, yes, and I'm going to finish now. If we were about to implant a ring in these patients, then we use exactly the template of the relative size ring to create this patch and design this patch. And then obviously this is the final result. You can see the patch doming towards the left atrium, leaving a lot of space underneath. As I said, this is an operation that personally I think that it is inferior to the transaortic approach for the obvious reason that we operate on a valve that otherwise wouldn't need any sort of operation. Thank you very much for your attention.
Thank you, Antonis. Surgery for Hockham is probably one of my favorite surgery. We do quite a lot as well. And so as you challenged Michele, I'd like to challenge you. First of all, the myectomy, I've got two questions. The myectomy, transaortic. To me, it was more effective from transmitral than transaortic. What I have the feeling is what we do is to to enter the septum with the knife and then go down and then again make a new plane, let's say, going deeper and lower and lower. So I had a little bit from the video the idea that you could just go, probably due to your very super small access, that you had just one direction with your knife, that you could not really go inside it was more like this than this and this, in and in.
Quite right.
This was my first point. Then I give you the second point. Obstruction in these patients is multifactorial. This is not just the septum. These patients have come up with different phenotypes, and the mitral valve, leaflet, cords, muscles, papillary muscles are always, I would say, in different ways, but always pathological. Anterior displacement of the papillary muscle, anomalous insertion to the leaflet, cords, leaflet that can be very long, pushing the posterior to the anterior. So almost invariably, we have to do something on the mitral valve. So this is papillary muscle mobilization, this is chordal cutting, secondary chordal cutting, or even, something on the mitral valve is always done. I would say, especially in those patients that come with a shallow septum. So the less thick is the septum in these patients that have obstruction, the more the phenotype is expressed on the mitral side. What is your experience? We always touch the mitral valve in this.
Yes,
always.
So let's talk about the first question. These are extremely valid points, and we can have a nice discussion about these points. So about the first one, yes, the move of the right hand is relatively in the same axis, and the axis is one line that is dictated by one finger incision because it is totally endoscopic. So the incision is one finger, and the line of the aortic annulus. So there are 2 points connecting this line. So the knife can go only this direction. But the left hand does all the work. The left hand pulls pulls down. So it is the operation is done not by the knife, but by the left hand. The left hand is the one that navigates the knife by pulling more or less. I mean, this is the important point. So this is something that I try always to teach to my fellows, that they have to use the left hand. If they don't use the left hand, they can't do endoscopic work. Endoscopic work, two hands, left hand, right. And the left actually does 3 times more work than the right. So this is the first point. And the second point about what you do in a case where you have involvement of, of so many things. Papillary muscles, cords, length of anterior leaflet, blah, 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 all these things. You know, we have long series from the Mayo doing the Moro procedure, and the Moro procedure is mainly, done septal myectomy. So yes, if you do an extended septal myectomy, probably you don't need to do many things in the mitral, but still you can do it even transaortic if you want.
Yes. But there are so many patients that comes with a septum of 20, 19, and they have obstruction because the papillary muscle are displaced.
Yes, you have to cut
the leaflet
accessory.
and the cords. So in this patient, myectomy alone is less effective than a gesture that you make on the mitral valve, because that is where...
I think, okay, I mean, there are obvious things, like if you have, for example, I can't remember the name of this papillary muscle, the extra one that, gets on the posterior surface of the anterior mitral leaflet directly without cords. I think it's Lancesi or something, I can't remember. But yes, you have to cut this papillary muscle. You have to do work on the mitral. If you need to do work on the mitral, you can even put synthetic cords transaortically. You have so excellent exposure, and we have done it many times, to do transaortic synthetic cords in the anterior mitral leaflet. But most of the times, you don't have to do all these things. An extensive myectomy is the answer, most of the times. But, okay, I mean, this is a discussion that can go on.
Many ways you can skip the cutter, you always say that. I will go next further with the next presentation from, yes, I don't see you, you are against the light. You are against the light, sorry.
I have 2 questions, Antonios. One, how many grams of tissue you remove, generally?
On average, I remove 10 grams of tissue.
10 grams?
10 grams, yes.
It's very much. And the pressure after the residual pressure, what is generally?
Well, peak gradient that we measure is 10 to 12, I don't know.
Good result. Now, I want to give you that now there is a device in China.
Yes, I know.
You know?
Actually, we had invited this guy. We invited this guy in last year's meeting in Milano. I don't know whether you met him.
These guys have more of 900 cases.
Yes.
Also pediatric cases.
Yes.
And performed the operation in beating heart from the apex, and remove in 10 minutes, 20 minutes generally, until 6, 8, 10 grams of the muscle, without problem the mitral valve. Mitral valve don't have after the insufficiency. It's fantastic operation.
Yes, indeed. Obviously,
I'm sorry, I'm interrupting you, but it's 1:15, and we are very late. We have to go with the next presentation, and I'm sorry about that. I don't like it. It's my fault because I've been moderating all sessions, so I take the responsibility for that. I'd like to call the next speaker from Dresden. We make another transaxillary presentation. Is Dr. Sorry, because this is a change in the presenter. I'll tell you the name, Dr. Ali Vagafi, correct? Transaxillary is not only for beginners. I'd like to invite the next speakers to be a little bit shorter with their presentation, so they make it double speed.
So, dear Chairman, and dear ladies and gentlemen, thank you for the kind introduction. Professor Dioizanio, and for giving me the opportunity to speak here today. I'm honored to be able to address your dear participants and share my insights as a resident being involved in a program of minimally invasive cardiac surgery. I hope that we can gain some valuable perspectives together and engage in a stimulating discussion. Let us now dive into the topic. But before I start with the actual topic, I would like to share a video with you that went viral on social media a time ago and caught my attention. Let's take a look at it, and everyone can reflect on it. It shows a Buddhistic monk who is climbing this kind of hill without any equipment. And the question is, does it look easy, or does he make it look easy? I suggest we have enough time to reflect on it. And in the meanwhile, I will delve into the presentation and the further slides. So from the beginning, let's address one point, actually the elephant in the surgical room. Regardless of the surgical access route, we are still talking about conventional cardiac surgery. And what options do we have available on the cardiac surgery table, which we have already explored maybe and gathered our experience with? We have a wide range of possibilities and options, from low-tech to high-tech, image-guided, 3D, 2D, robotics, all kind of solutions. And this fuels actually the discussion about which option is the most optimal, maybe for the surgeon and also for the patients. But what is in the goal of all these procedures actually? To put it more provocatively, why all the commotion about this issue? Which kind of surgical access route we use? And there are some bullet points, I would say. Maybe it could be cosmesis, maybe it could be patient satisfaction, reduced trauma for the patient, or maybe also for ourselves' ego. Now, let's be more concrete about the facts and have a look at the numbers of the SAVR versus TAVI in Germany. And you see a clear decrease of the numbers of SAVRs. I know that this event is primarily focused on the mitral and tricuspid valves, but I want to illustrate our MIG philosophy using the surgical treatment of the aortic valve. And it is an indisputable fact that the trend is shifting in favor of TAVI over SAVR, with SAVR procedures continuously decreasing nationwide in Germany. But let's take a closer look at Dresden. Despite the increasing TAVI numbers, we were able to increase our case volume by 20%. And we are still going strong with this concept. Under the leading of Professor Kappert as the program director, we continuously leveled up our SAVR program and shifted to a more and more less invasive procedure, went from sternotomy to upper partial sternotomy, and right anterolateral thoracotomy was implemented in 2015. And we went for right lateral transaxillary thoracotomy in 2019. And in the graph, you can see that with the beginning of 2020, we could go nearly for all comers. And let's have a look, a closer look at this graph. With the implementation of right anterior thoracotomy, we were still selective despite we had increasing numbers of MIGs doing SAVR. But with the implementation of right transaxillary, we could finally go for all comers to provide this treatment option for every patient without nearly any other selection. And this takes us to the core question, does the nearly universal adoption of transaxillary validate the surgical access route, or does it reflect the strengths of a broader underlying concept? And the right lateral transaxillary access is actually far beyond the surgical access route. It's kind of a piece of a larger puzzle. And putting them together, these pieces, it stands for a holistic concept which we call MICLAT-S, which stands for minimally invasive cardiac lateral surgery. And the core concepts and core philosophy of this approach is one incision. So you have one axis concept to surgically treat all structural heart diseases. Direct vision, you do not need any sophisticated equipment, and a perfect view on the surgical field is in any case guaranteed, and you have also superior cosmesis by an invisible scar. So if we would introduce MICLAT-S concept by a portfolio, it would be 4 points which have to be pointed out. And it's the first one, safety, at least as safe as the traditional full sternotomy. And these data are supported by the real-world data analysis from 1,000 patients data set. And you can see all-cause in-hospital mortality by 0.9. I continue with the further slides. Its efficacy have shown high success rates in terms of procedural execution in SAVR, but also in other procedures. I will show you the numbers also. You can see operative mortality was 0%, conversion to sternotomy was less than 2%. Repeated cross-clamping also less than 2%, and other cannulation strategies were also less than 2%. And I think this is the most important point, and this is the reproducibility. It's a highly structured and standardized surgical steps, and the reproducibility is the cornerstone of a profound education for a training program. And here I want to show you an organigram of the surgical staff which is involved in our MIC program. And you see the top of the organigram is built by the head of the department, the program director, 2 senior consultants, and 2 junior consultants who all performed the entire surgical procedure, followed by 1 specialist who prepares the surgical stride prior to cross-clamping the aorta, and also 3 senior residents who performed the thoracotomy and the femoral cannulation, and 4 junior residents who prepared the cannulation site. So 64% of the whole surgical staff is involved in the MIC program. And the next point, which is also crucial, is the versatility. It's applicable to all structural heart diseases. So we have in 99.7% of cases the possibility to perform isolated AVR. Mitral valve surgery, we went for 98.7%. There is also the possibility to perform concomitant AVR and mitral valve surgery, but also mitral valve surgery and tricuspid valve surgery. And the surgical removal of cardiac tumors, primary benign cardiac tumors like myxoma, like fibroelastoma, were possible in 100% of cases. So just to demonstrate the strengths of this one axis concept, I prepared a short video in which you can get an impression on the possibilities we have by this axis route. So this is the javelin throw position, the typical positioning of the patient. These are the anatomical landmarks. I think this was addressed in the recent cases. You have excellent exposition of the aortic valve. Another case of aortic valve surgery. The sutureless valve facilitates, without doubt, the implantation procedure, but we have also the possibility to do it also in a sutured form. And it can be also tied by hand, as you can see. So this is an example of a Bentel procedure, which was performed by Professor Kappert. And this is the aortic root replacement. I would continue because of the time pressure. And you want to do mitral surgery, you have also the possibility to, and you can also go for the right heart without any problems. So I would continue with the next slide. The question was transaxillary approach, is it only for beginners? And I think there is a clear answer, and there is also one answer. No. Not only for beginners. But it's a concept, and I think the only concept to establish a 100% all-comers mixed program. What is the surgical pathway for MyClot-S for the next generation of cardiac surgeons? It's a structured, modular, step-by-step approach. And in the program we have in our clinic, it is led by Professor Kappert. We have the module brick 1, preparation of the femoral vessels as the cannulation site. The module brick 2, performing the right transaxillary thoracotomy. Module brick 3, femoral cannulation and preparation of the surgical site prior to cross-clamping the aorta as the last module, before performing the entire procedure. So, at this side, I want to cite my mentor, Professor Kappert. Surgery is actually not made for the surgeons. Surgery is made for the patients. So we do all this kind of stuff to gain better outcomes for our patients. And to get to the conclusion, I would say there are 3 points by which we can sum up the MyClot-S concept. It's high penetration rates of minimally invasive access routes. You can see in Germany, we are leading with 99.2% of cases performing aortic by a minimally invasive concept. And you can also see the numbers in Germany and UK and US. And also the same for the mitral valve procedures. And the superior cosmesis, you can see on the left side the transaxillary incision, and on the right side a robotic approach, and it's kind of comparable, and it's high reproducibility because of its standardized training program to secure a strong next generation of cardiac surgeons. So these are the 3 points I would say are crucial for this program. And I would like to end my presentation with a quotation from Professor Ramchandani, who told about the MyClot-S concept. You do not show the people what you are doing, you show them what they can do. Thank you very much for your attention.
Thank you very much. It was a great presentation. I want to know the software you use for this presentation because it was beautiful, and we accept. I got convinced 5 years ago, so I don't have questions. I don't know if there is one from the floor before we go to the next presentation from my friend Jörg Kempfert. This was astonishing. Thank you. Jörg Kempfert is the next speaker. He's talking about complications.
So actually it's not my topic, it was meant to be done by Joe Zaharais, who got caught in the UK. So I'm just presenting his slides and his ideas of, on his behalf, and obviously it's his complication because you never have your own. Okay, so Joe used to be a fellow with Hugo van Namen, who was truly one of the pioneers in all the minimal invasive, especially endoscopic procedures. And a quote from him is that he's tell you all the mistakes that he made, and you will make your own mistakes, but please don't repeat mine. And I think this is very true, and this is also why we should come to a culture where we have more complications and not only show the nice life-in-a-box cases. So let's see what Joe has his thoughts on the complications. So this is a very nice picture. I don't know where this pub is, but I think some of us also should have a beer there, right? Master of Complication, what a nice name. Okay, so what is a complication? So what is the first thing you consider always is conversion stenotomy. The question, is it a complication? And I think it's not a complication, it's a bailout. And so we need to, if you think of it, go for it. I think it's not a failure, especially not early. If you convert to this stenotomy, do it. It's a disappointment for the patient, also maybe for your ego, but it's not a real complication. So this is what Joe put up from the literature in regard to minimally invasive mitral valve surgery, where the most common complication. You can see it's groin seroma, and if further down you go to a list, the more unlikely it gets. So let's have a quick thoughts on all these different things. So groin seromas, limb fistulas, this is a huge issue. It's very annoying. It's not a deadly complication, but it's a very annoying one, very hard to treat. So what can you do? If you want to go for cut down, try to go higher than you think. The higher you go, the less problems you might have. Some people even go above the ligament. And my personal view is just move to percutaneous cannulation. This will eliminate this problem. If you have very obese patient, the femoral region is a region you shouldn't go. Also in a very obese patient, I go transaxillary. Also the femoral from the vascular quality would allow to go femoral, but the axillary access is also not easy in obese one, but it's less prone to complication if you have a lot of fat down there. Neurological events, this is the Achilles heel of all the minimal invasive that is associated with femoral cannulation. I think it's now common sense that a small incision is never going to create a stroke. It can't be. So it is due to the retrograde perfusion, which is different to a stenotomy. That is a problem. So the mobile plaques, the soft plaques, the so-called dirty aorta, typically in the abdominal segment, is a problem. So you need to recognize this. And if you see it beforehand, and ideally CT, if you don't do CT for whatever reason, then yes, at least have a look on a TEE in the ultrasound. Don't reverse the flow in those patients. Just go antegrade, which typically is axillary artery. De-airing, it's a lot of topic, a lot of discussions about this one. I personally don't believe that a couple of microbubbles are going to produce a real stroke. You might see some seizures or these kind of things, but a stroke is very unlikely. We all use CO2, and the de-airing and the setup of our surgical setup is basically the same as stenotomy, so I don't understand why it's brought at each and every time. So it's mostly not a problem. Something that I found interesting when I found this on Joe's slides is that the soft tissue retractors, at least from his point of view, is quite important, not only to gain access, but to avoid fat embolism. And it's something that we all know, especially in obese patient, when things get a little bit messy, that we need to really make sure to not have any of the fat material in the circulatory. Pain. Pain is a problem. Pain is also diminishing all the benefits of the minimal invasive approach itself. So my personal view is if you can avoid it, just don't split the ribs. This is typically going to help with pain. Because the pain is not, a skin incision usually is not so painful. It's a rib spreading that is going to trigger the pain, and the worst case scenario is a fractured rib. So some centers now, I think Innsbruck started now to do preemptive analgesia, so meaning you do a block or local anesthesia before you do the skin incision. There's some scientific rationale behind that. That might be a good way to go. Definitely use intercostal blocks, so different types of things to do. And cryo-analgesia is something that's especially popular in the US. I'm still not 100% sure which cryoprobe to use and how long it lasts. But it's definitely an option to discuss in a team. Nerve damage, there are a couple of nerves that you can hit. The most common one is the superficial femoral nerve when you do cut downs in the groin and you're a little bit far too lateral, but it has been reported, but I think it's something to avoid if you go more medial. Intercostal nerves, this is what we discussed, this is pain issue. The phrenic nerve, this is what everybody talks about. Yes, you can, of course, injure it if you go too lateral for your pericardial incision, but I think this is rarely the case. Typically a very beginner mistake, or in a redo, or if your lung adhesions. I think the most common way to injure the phrenic nerve is if you do cryoablation, especially if you do the mitral annular line, then it's very easy to also cryo the phrenic. The good news is that most likely it will recover, but it will take a couple of weeks. So femoral vessel complication. This is again bringing us to the most Achilles heel of all the minimal invasive. So this is again the issue of cut down versus percutaneous. There are now a couple of studies, one from Sweden, one here from Jena, from Dön's group. And basically, if you just look at the numbers, the percutaneous option is more safe. It's a little bit more difficult to do. It's more cost. You need a little more devices, but it is. If you sum up the complication, it's the safest way to go. Very rare complication is obviously atrial venous fistula, but this has become less since we use all ultrasound scanning, not only to see where we are, but also how to do the puncture. So intracardiac damage due to suction. This is something that I never had it in a mini, but I had it a couple of times in a sternotomy, so I do understand Joe's rationale to put it there. So the thing is that you can, especially if you have malleable suction devices that are also, on the other hand, have some positive aspects, especially in the minimally invasive setting, because you can put them wherever you want to have them, and they typically stay there. But then the downside is you can perforate. Typically, it's the left ventricular apex, and you will recognize whenever you try to come off pump and you need immediate fixing, most likely through sternotomy. So I never use these rigid things in a minimally invasive setting. Aortic dissection. Again, that's the femoral issues, retrograde cannulation, it's lack of imaging. It's always when you push the boundaries, then you're going to have this problem. Other than that, it's very rare. Just accept if a femoral is 5 millimeters, don't force it. I mean, you can go for 15 French cannulas, not a problem. Don't do too big cannulas. This is typically, if you come from sternotomy, your perfusion crew is always pushing you to go with these super large cannulas, 22 or something. Nobody needs a 22 cannula to do a mini. I mean, 18 French for male is definitely not. But this brings us to the perfusion pressures on the lines. So I think I saw this already. If you buy a brand new lung machine, all the alarms are set to 300 or something like that, or 250, I don't know, ridiculously low. And there's no harm if you have higher pressure on the arterial line. This is not that the pressure is going to act on the vascular system. It's only in the line. So it's not a problem. And also use good cannulas. So they're different on the market. So I think the one that we can all have used and found good is Updeside by Medicals or Medtronic or Maquet HLS. You need to have good femoral cannulas with side holes and thin wall with good dilators, not too much of a shoulder, all these kind of things to avoid the femoral issues. So if you anticipate problems with either line pressures or venous drainage, and you have a good hemoglobin to start with, just lower the flow. Nobody needs 2.5 index for a short, quick mitral procedure. You can go down to 80%, but just you need to be on a safe side and do a DO2 controlled. Coronary artery injuries, I think this is not specific to the mini, but in most minimal invasive centers, 99% of all the mitral work is done minimally invasively, so all the coronary lesions are going to show up in the mini cases, and some people typically try to blame the mini, but this is absolutely nonsense. It's a problem of mitral valve surgery. I think we have a long route to go there. If you compare it to transcatheter, we're not good there. TOE is kind of helpful, yes, to pick up the wall movement abnormalities. Also, it is possible to show the circumflex by TE. You can see it in the upper right image. But so lesson learned after a couple of cases that also I had myself. Whenever I am in doubt, I go from the OR, cath lab, ICU. If you cannot come off bypass, then yes, you need to put ECMO and then cath lab. It's always coronaries. So if you suspect something, go and have a look, because most of that can be stented. Aortic valve injury, it's very rare, but typically it happens if you go for mitral valve replacement, and also more common, obviously, for complete versus a partial anaplasty system. So if you see it in the OR, I think the most important thing is be honest to yourself, don't cheat away. I know that usually those are mild to moderate, and maybe there's a discussion in the team to leave it, but it wasn't there beforehand, so be fair and fix it. And if you're capable, you can also do it through the same mini excision. Other than that, you need to patch the non-coronary nadir leaflet. So unilateral pulmonary edema. This is a weird thing that had even a real investigation from NHS in the UK. And so it's very inconclusive. So my bottom line is, if you use a double lumen tube, these centers sometimes see it. Those centers that do never use double lumen tube apparently have never seen it, which I cannot explain. So in conclusion, it's normal to have some kind of mistakes and failures, But you should take a different approach to that, because most complications are not real failures of yourself, but just learning opportunities, at least for your fellow colleagues, to not repeat the same mysteries. And we have, there's a thing called the half-throne effect, which means the more you look at it, and the more you talk about it, and the more you discuss it, most likely those things will then go away, or at least become more rare. Thank you.
Thank you. I'm impressed, Jörg, by how good was your presentation on someone else's slides. I mean, fantastic. One short question, only one if there is one, otherwise we go to lunch, right? And then we see here in maybe, I don't know.
When?
It's 20 to 2, maybe we see here at 2:30, right? 2:30. At 2:30, there are two missing presentations from this session. We will start with that one and the next one. Thank you very much. Have a good lunch.